Good morning, everyone. Welcome to the post-Congress workshop. And today we are taking you through a journey the fetus takes across the trimesters, discussing the common problems that we face in day-to-day practice. And for that, we have a very good team of experts from Delhi and from outside Delhi who will be helping you understand and solve the dilemmas of managing the fetus across trimesters. I'm really grateful for all the experts who have taken the time out to join us. So, without delaying, I would ask Dr. Anubhuti to start the program.
A very good morning to all, the esteemed faculty and delegates. As ma'am said, we will be taking you through the journey of fetus across the trimester, starting from aneuploidy screening to fetal growth and an approach to malformations by all our eminent faculty. And at the outset, we would like to express our most sincere thanks to the AOGD team for the support and organizing this workshop. Now, I would like to invite our two distinguished moderators for the first session on the screening conundrum. Dr. Chinmay Rath, a very dynamic, enthusiastic fetal medicine specialist. Ma'am is the director, Fetal Medicine Center, Navodaya Hospital. And I also invite Dr. Akshata Sharma, consultant fetal medicine, Apollo Center for Fetal Medicine, Indraprasth Apollo Hospital.
Thank you. Thank you, Dr. Anubhuti. So shall we just move on directly to the panel?
Yes, ma'am.
It's really nice to be amidst the stalwarts of AOGD and some of the friends from other parts of the country as well. And the first panel is on screening for fetal aneuploidies. And whenever you think of a fetal medicine specialist, the first thing that comes to your mind is screening and Down syndrome. So somehow it's become synonymous with fetal medicine. And for that, we have a very eminent panel here to address some of the issues which are looking beyond NT for aneuploidy screening in the first trimester. My co-moderator is another young, very dynamic, I would use that word for her, Akshata Sharma. I've known her since her student days, and she's gathered a lot of national and international recognition thereafter. It's been a proud privilege to know her through the years. She's currently a consultant in the Indraprastha Apollo Hospital in fetal medicine and has been part of the WHO multinational project for fetal growth charts. So it'll be nice to have her with us as a co-moderator. We also have Professor Madhulika Kabra from the All India Institute of Medical Sciences. Madam has been a stalwart in genetics, and from my student days, I know her. And she's been part of many important technical committees in this country. And somebody who has, I mean, I really don't feel good enough to introduce her to the gathering because she is the one who's introduced us to many concepts of genetics and screening in fetal medicine in India. Welcome, ma'am, to the panel. We look forward to your inputs. We also have with us Dr. Krishna Gopal, our colleague from the Society of Fetal Medicine, and he is FMF certified for the fetal medicine scans and has done a clinical fellowship in Singapore General Hospital. Currently the Secretary of Society for Fetal Medicine, National Secretary for the Society of Fetal Medicine, and is working on the Fetal Echocardiography Committee of the same society. Reviewer of the Journal of the Fetal Medicine Society, and has a state-of-the-art ultrasound and fetal medicine center in East Delhi by the name of Advanced Diagnostics. Welcome, Dr. Krishna Gopal. Akshata, would you like to introduce Dr. Sumitra?
Yeah. So good morning, everyone. Dr. Sumitra is the senior specialist and an associate.
I think we are not getting her audio very clearly. So Dr. Sumitra again is one of our very senior consultants, currently working in the Safdarjung Hospital. And she has done a fellowship in maternal fetal medicine in AIMS, Delhi, Joint Secretary of the AOGD 2015 to 16, a state trainer for the comprehensive abortion care under the Ministry of Health and Family Welfare, and lots of accomplished achievements in her career. Madam, it's an honor to have you on our panel today. So we look forward to your inputs. Dr. Vandana Chadda, again, a very, very dear friend. and with someone with whom I have shared the seats in many conferences, and we have had on stage and off stage interactions. One of the brightest fetal medicine specialists in this country. Her brightness started from her school days when she was the All India CBSE topper, received many gold medals in her MBBS, and went on to have a brilliant career where she was trained not only in India in genetics as well as fetal medicine, but also did a postdoctoral fellowship in the maternal fetal medicine in the University of Toronto. And I've known her since many years, where she used to work and present beautiful presentations in all the conferences. Currently consultant in fetal medicine and genetic medicine in Sattva Fetal Care, New Delhi. Welcome, Dr. Vandana. So I think Dr. Nandita is not joining us. So with this, we will move on to our panel discussion. Akshata, do you want to share your slide? Okay, so the topic that we have been given is the screening conundrum, because there's so many confusions in there and so many ways to interpret certain tests that it is nothing less than a conundrum. And put it on slideshow. Arpita. Move on to the next slide, please. Next. So this is the first case that we have. It's a 35-year-old primi gravida spontaneous conception who has just come for a nuchal translucency scan. So Dr. Krishna Gopal, who's one of the imaging specialists, will help us in just interpreting this image. Do you want to tell us what do you see when you see an image like this on the NT scan?
Good morning. At the outset, I must thank AOGD committee for giving me this opportunity to be part of this STEAM panel. As far as this case is concerned, the first thing we see that this is a mid-sagittal image of the fetus. Second thing, for the audience, I want them to know that whether it is following the fetal medicine protocols of having a correct NT measurement image. So we are seeing here the correct magnification in the form of head and upper thorax is included. We are seeing here that measurement has been taken correctly, because the crossbars on the white lines. We are also seeing that fetus is in the neutral position, and it is not and it is the midline, because we are
So
not.
I want to take this forward from there. I think that's a brilliant thing that you said, that we have to adhere to the FMF protocol. And suppose that has been done, do you want to comment on the nuchal translucency? Do you think it's looking normal?
Ma'am, subjectively it is on the higher side, but what we need to check that the nuchal translucency is above 95th centile for the given.
For that CRL that it is. Excellent. That's the point we wanted to bring out. So there is a picture here. It shows there is increased nuchal translucency subjectively, but like he very rightly said, we need to correlate it with the CRL. But considering the measurement is 4.7 here, most likely it will be high for whatever CRL, because the upper limit for CRL of 84 is also around 2.8, 2.9. So we can safely say that there is increased nuchal translucency. So Akshata, next slide, please. So Dr. Nandita is not here. I just go on to Dr. Vandana Chadda. What will you do next once you see increased nuchal translucency? Unmute yourself, please.
Yeah, so I'm concerned about that nuchal translucency, and that sort of picture is enough for me to offer the patient invasive testing directly, because I'd be concerned about a lot of things like aneuploidies and deletion duplications and so on.
You don't want to consider cell-free DNA here?
I would give her all the options. Like, I do want my patient to have an informed choice. But as a clinician, my inclination is definitely to go for invasive testing vis-a-vis cell-free DNA, looking at this picture that you just shown me.
You think an invasive testing is good? So let's move on to Dr. Sumitra. What do you think are the implications of increased NT?
Yeah. Thank you, Dr. Chenmay, and I thank the AOGD for having me here today on the panel. And coming to the implications of a high nuchal, as we all know that there are associations of the high nuchal with aneuploidies, with structural anomalies, specifically cardiac, and some other non-cardiac anomalies also. And then the association with certain syndromes. So I think I agree with Dr. Vandana when she said that we would go for invasive rather than cell-free DNA, because cell-free DNA would only look at these five, 13, 18, 21, and the sex chromosome. And having said that, a review by Nicolaides has suggested that fetuses with a raised nuchal, the risk of abnormal karyotype or risk of anomalies with a normal karyotype or the risk of fetal death increases exponentially. So up till 20 weeks, I think you put up the slide there also, that if you see the nuchal is between 95th to 99th centile, the abnormal karyotype would be there in 3.7%. With a normal karyotype, but major anomalies would be around 2.5%. Then the risk of fetal death would be around 1.3%. However, you would find alive and well deliveries at around 93% cases. So as the nuchal increases, so from 3.5 to 4, the risk increases, and I would say at a nuchal of more than 6.5, the alive and well would only be around 15%. If you've ruled out the karyotypes and you've ruled out the syndromes and you've ruled out the structural anomalies. So basically, we have to look at the increase in risk with the rise in the nuchal, and accordingly, we need to counsel our women.
So thank you, madam, for this elaborate discussion on what all could have happened with increased NT. So now, Dr. Vandana, you wanted to do the invasive test, and that seems to be corroborated by the other expert as well. So if you do an invasive test, what test would you prefer? I mean, what is that you will ask out of that invasive test?
Definitely, if my patient wants an early result, FISH can be done, and FISH alone would rule out a bulk of the anomalies that I'm looking at, and a backup microarray would corroborate that, plus pick up additional deletions, duplications that the FISH might miss. So let's say we start with a FISH microarray and we can store DNA. So in case the FISH and microarray are normal, then we do have the options of doing any backup DNA-based testing on any clinical exome or genetic panels that we think of later based on our clinical findings on the ultrasound.
Now let's talk practically. This woman was about 12, 13 weeks when you did the CVS. And then you want to ask for some tests. Are you going to ask for all the tests at the same time, or you're going to go in a stepwise manner, because at the end you need a result?
I think I'll be okay to do a microarray alone. But you know, clinically, if I do a FISH and a microarray and my FISH comes back as say trisomy 21 positive, I do have the option of doing an early abortion as well. So if my patient can afford, my preference would be to do a FISH and keep the DNA for the microarray in case the FISH is normal. Or I can do both the tests together based on the patient's brain capacity. I think I'd be doing FISH and microarray both together.
Okay, Akshata, just move on to the next slide. So is there a role of adding biochemistry in this case?
With this kind of NT, I would hesitate to use biochemistry as a adjunct to the overall testing. I think this nuchal alone would be good enough for me to decide on my invasive testing. So, the biochemistry may just not be useful too much.
When we are talking about beyond aneuploidy, what we understand is with that kind of NT, this biochemistry may not be useful for aneuploidy screening. Also, it has implications in terms of placental issues and all, and that's a different matter altogether. Right now, for aneuploidy purpose. So in this pregnancy, what happened was a microarray was done, things were okay, and then she continued. She had an uneventful delivery. But here I want to bring in Dr. Madhulika, our senior geneticist here. Madam, we discussed so many possibilities with an increased NT, but we stopped at microarray. Should we have done an exome?
Okay. First of all, thank you very much, the AOGD committee, for involving me in this interesting panel. So when we are talking of increased NT, and as Vandana said, because the NT is towards more than 3.5, the cutoffs which are taken are different. So invasive would be a good option, but definitely depending on the choice. So see, the majority and the aneuploidies are the major cause of increased NT. So what we would usually do is depending on the time available, gestation of the patient. So we would usually try to exclude aneuploidy. So it could be by FISH or by QFPCR. Following that, choosing between microarray and exome. So if you collectively see, if there is isolated increased NT and if you have sort of excluded aneuploidies, common aneuploidies, then in about 4% of cases would have other chromosomal abnormalities. And if there are associated congenital anomalies, that it increases to about 7%. So having said this, the submicroscopic abnormalities are around 2%. Right. So overall, if you see the cause for increased NT, overall chromosomal is much higher as compared to single gene disorders. So if you want to do in sequence, this would again depend on the time available. We would do CMA first, and CMA would pick up other, because the other chromosomal abnormalities are many other aneuploidies other than the 5 which we would look for in say QFPCR or in FISH, and then these would be picked up by chromosomal microarray. If you look at the single gene abnormalities, which would be picked up by say exome sequencing, it is around 2% of cases you will have single gene abnormalities, and majority of them would be Noonan and the other rasopathies, about 50% of them. And then there are other single genes also like Roberts and Cornelia de Lang, multiple pterygium and all. So though overall submicroscopic would also constitute about 2%, and overall single gene also would about 2%, but then overall chromosomal being higher, we would prefer to do CMA followed by clinical exome. But if the time is too short and affordability is not an issue, in that case, we can do both of them as parallel. And obviously, if none of these are positive, we would look for other associated abnormalities, which may be associated like cardiac and skeletal and so on and so forth. So
what I understand, thank you, ma'am, for that thing. What I understand is, while we have a choice of doing a lot, we have to sometimes tailor make the request for investigations depending on factors like what are our primary suspects, cost involved, time involved. Because suppose you do a FISH and you find Down syndrome, then probably the rest of it is just a part of the Down syndrome scenario.
So I mean, because majority you will pick up the common aneuploidies. So if the time is there, doing in parallel, say QFPCR or FISH along with CMA would be a lot of cost for many patients. So if you have time,
and suppose we did find something in the QFPCR or FISH, we might not go ahead and do the whole.
So that cost would be saved. So if we have time, we can wait for that, because it doesn't take a lot of time to get results of FISH and QFPCR.
But practically the problem comes when all the results come normal, because this was a case with increased NT, cytogenetic microarray was normal. We haven't yet done an exome. So even now, after the baby is born, we can't reassure them completely.
Yeah, but if the baby is phenotypically normal, it is unlikely that he would have.
Very, very rare, but sometimes we get surprises later on. With
Definitely.
So that's where the story doesn't actually end. As the knowledge increases, the ignorance also increases. So that's now we come to case number 2. Akshata, would you please take on this case?
Right. So again, could I please request Dr. Krishna Gopal to explain the ultrasound findings in this lady who has had a previous pregnancy, a termination for pleural effusion. This was a non-consanguineous couple, and she had come to us for her second pregnancy. Please describe the ultrasound findings, Dr. Krishna Gopal.
Ma'am, there are the cystic structures, symmetrical cystic structures, bilateral, at the cervico-occipital junction of the neck, and it is differ from the nuchal edema, because we are seeing here a nuchal ligament. I would like to do a detailed ultrasound examination as well as fetal echocardiography in this case. Plus, I would also like to offer the patient microarray and KT. In this case, we will also ask the patient for a follow-up at every 4 weeks for the to assess the evolution of the cystic hygromas, plus the development of hydrops in this case.
Right. So as Dr. Krishna Gopal rightly said, the first impression is that it is an increased nuchal translucency. whether it is septated, not septated, doesn't matter. It is increased nuchal translucency. You are seeing what is called as jugular lymphatic sacs here. However, that is not going to make our management different. What we would like to remember is that she's had a previous termination for pleural effusion. So there has been an abnormality in the previous pregnancy. And like he said, our plan for this pregnancy would be that first we will like to do a targeted scan, look out for any structural malformations. Like we just saw in the previous case, we will be offering her a FISH microarray and a DNA storage. Now, the next thing here would be that because there has been a previous pregnancy, in any case of increased nuchal translucency, we would like to call the patient back a little earlier, maybe at 16 weeks for an early anomaly scan, because that's when you'd like to look at the cardia. That's when you'd look at, whether the bones are growing well, is there hydropic changes? And if there is something at 16 weeks, maybe we offer them further DNA analysis on the stored DNA. And of course, followed by a detailed anomaly scan. So that's very right, Dr. Krishna Gopal. This would be the plan that we would have for this patient. Now at 16 weeks, we're seeing her. And as you can see from the images, we are seeing that the nuchal fold is still 6.2, 6.3. It is persistently increased nuchal fold. So Dr. Sumitra, could you please elaborate on the causes of persistent increased nuchal fold for us?
Yeah. So Dr. Akshata, I think if you look at this case, I suppose the KT and the array was normal. And we have moved on to the fetus at 16 weeks. So in a large study of 675 fetuses, Milado has reported in 475 of them still, like you very correctly said, we should do a very detailed anomaly scan, because there were certain cardiac defects which were picked up and certain structural defects like the orofacial clefts which were picked up. And so it is very important that we do a very detailed structural anomaly scan. And then a few studies have also reported that there is an association with, recently in the White Journal, there were 9 cases with thicker nuchal and 2 of them were Noonan. So I think we should start looking at, and then the history is there of previous history of pleural effusion in the previous fetus. So we need to look into that and associate the phenotype in this time. And again, we have a thicker nuchal. So I think we should look into the genetic syndromes, the Noonan specifically in this case. And I would also say that, regarding fetal anemia or infections, as you put up, there would be other ultrasound findings, Dr. Akshata. Like fetal anemia, you could see the MCA, PSV, and infections, of course, placentomegaly or periventricular calcifications. And so the findings on the ultrasound would really give you some more directive as to which process you should follow. So I think here the genetic syndrome, the Noonan, should be investigated. And there is association with some inborn errors of metabolism also, but again, the associated ultrasound findings would also be there, like the stippling of bones, maybe the echogenic, bright echogenic kidneys. So I think this scan here at 16 weeks becomes very important. And we go in for a genome. Yeah, so we go in for an exome, and yeah, so we put up the report last.
In this case, now, again, if you look at the chronology and the time that we have, we've already spent 2 weeks in getting the microarray. She is 16 weeks persistent nuchal still there, and then we offered for an exome. The exome, unfortunately, came out to be Noonan syndrome. This was something that was explained to the couple. And after costly investigations, we did tell them that, yes, this was what we are seeing. So can I quickly ask Dr. Madhulika, ma'am, how will you further counsel the couple now, ma'am? Now that, previous pregnancy as well as this pregnancy, we're seeing a problem. Madhulika, ma'am?
Madam, do we have you? Otherwise, I think Dr. Vandana, you can take the question.
Hello, can you hear me?
Yes.
Yeah, Dr. Vandana, we can hear you.
Yeah, so we know that Noonan syndrome is an autosomal dominant condition, and there can be variable expressivity, variable penetrance to these disorders. So there will always be a sort of doubt
Move the slide.
what sort of manifestation the baby can have after birth. And so counseling becomes a little difficult, and it's a little difficult for the parents to take decisions sometimes in terms of how the phenotype will present later on, and how. So we've also had a few cases where the mother or one of the parents had a similar mutation as the fetus, and it becomes very difficult for the parents to make a decision, keeping the scenario of variable expressivity in mind for some of these autosomal dominant conditions.
Yes, so we will discuss the chance of recurrence in the further pregnancy, and that is what we also.
In fact, I remember one doctor we had who kept calling, and I think some of us shared that patient who kept calling for a couple of years, even after the baby was born. She used to have the same mutation as the fetus. And
I
both
got disconnected. Sorry. Yeah.
Yeah, Dr. Madhulika is back, so she can.
Quickly, ma'am. So this had a persistent nuchal fold,
Yeah.
and
Yeah.
it turned out to be Noonan's. How will
Yeah.
you further? Dr. Vandana has already told us that it's an
We
autosomal dominant.
discussed about autosomal dominant and
Yeah.
incomplete penetrance. Anything
Yeah.
else, madam, would you like to
Yeah,
add to it?
so now this particular gene, there are multiple genes which are implicated in Noonan, and this constitutes a small proportion of cases with Noonan. It can express both in autosomal dominant recessive form. So here it is dominant. So here we need to remember that when we are counseling the parents, we need to have a very detailed and evaluation of the parents, because the phenotype can be very subtle. And it has been found that in about 30 to 75% of cases, the parents are actually affected. And because we are not able to look for subtle features, we may say that they are not affected. Right. So that issue may be there. And penetrance is quite good actually in Noonan patients. So if either of the parent is carrying the variant, then the risk of recurrence is going to be 50% in the
But
next
that is the
pregnancy.
challenge of diagnosis, madam. Suppose
Yeah.
the parent is carrying that. Is that
Yeah.
enough reason for us to suggest termination of pregnancy?
So now the termination of pregnancy would depend on what the parents choose to. So we have to tell them about the phenotype of the Noonan syndrome. What are the outcomes? Does the child has any severe cardiac involvement? Because that's the main reason that these children may have problems. The stature problem and all. We need to tell them about the management of growth, and the choice of terminating or not terminating would entirely depend on the family. But the risk for next pregnancy would depend on either of the parents are carrying the variant. If they are not, then it would be less than 1%, very low. And if they are, then it would be 50%. Choosing to terminate or not to terminate will depend on what they decide. Our job would be to tell them in detail about the disorder, what is going to
Like
happen.
Dr. Vandana said, that is the
Yeah.
dilemma there, madam, because we also
Yes,
don't know, we can't
definitely.
comment on the penetrance. So this will be more an empirical
Definitely.
decision.
So what we can look for is a cardiac defect, which might determine the prognosis, particularly hypertrophic cardiomyopathy and other disorders which may be there in Noonan
Right.
syndrome.
So the next step would be testing the parents. That would mean, and
Yes.
then further, yeah. So
Yeah, definitely.
In a way, you are back to square one, because after you've had a result like this, you go back and recheck your fetus to see the ear, see the pulmonary valve, look at things which you feel that could
Yeah, that's right.
prognosticate. Yeah.
Yeah.
So I think Dr.
So,
Krishna Gopal had highlighted that right in the beginning.
yeah. So
That
Vandana, important thing here would be that this is a likely pathogenic variant which is there. So that kind of situation is more difficult if you have a VOUS, if you have a variation which is not clear if causative of the disease or no. But in a likely pathogenic or a pathogenic variant, we are more or less sure that some phenotypic features are going to be there. And we have it in a known gene and things
no,
like
ma'am,
that. So,
I'm just asking you as a
yeah.
layman in genetics
Yeah.
that
Yeah.
is it possible to get a likely pathogenic variant as a carrier status in the parent as well?
Yeah, so the parents might be having a very subtle phenotype, which might be missed if we are not evaluating them very carefully. And as I said, Noonan syndrome penetrance is usually good. So you may find some very subtle features. Occasionally, they may be non-penetrant as well. So if either of the parents is having that variant, then the risk becomes 50% in the next
No,
pregnancy.
what I'm asking, madam,
Yeah.
is it likely that if the parent is carrying it and not showing it, that would be a variation of unknown significance in your classification?
No. So
Not
this
like that.
variation is known to be a likely pathogen. It's a likely pathogenic variant.
And it is still
So,
possible that one of the parent might be carrying
yeah,
it, but not
be
manifesting.
carrying it, but not manifesting, or manifesting in a very, very subtle manner.
way.
So there could be a ascertainment bias if we are not evaluating the parents carefully. for
So
even
let me make a point.
minor
Thank you, ma'am.
phenotype. Yes.
We need to move. Actually, let me make a point here for all obstetricians who are watching this, because while all of us are enjoying this discussion and we are kind of on the same page and we deal with this on a day-to-day basis, for a regular obstetrician, this confusion is too much. See, as even people who do genetics every day, I'm confused that whether this, if the parent carries it, what is the significance. So what important thing we need to take home here is, do not try and counsel these patients all on your own. Please involve a clinical geneticist for sure, because the remit of genetics is very wide, and the patient needs to hear directly from the geneticist rather than from us cooking up the whole thing and serving it to them. We need to understand, we need to educate ourselves, but the final counseling has to be done by the clinical geneticist in accordance with the obstetrician. So I think that is for case 2. And now we move on to case 3. This is again a 30-year-old primi gravida, low risk in first trimester screening. Akshita, just move the text, please. So here the point that we'll be noticing, again, we've used Dr. Krishna Gopal for all our imaging options. So sir, do you think there's something very obvious on the picture that you can tell us?
Yeah, there is absence of equal sign. So it is.
So there is an equal sign here. No, why do you say absence of equal sign? I'm confusing you because this is just because many of the doctors, they don't take care about where is that equal to sign.
Yeah.
Equal to sign.
This is not correct equal sign actually.
Absolutely, yeah. So because a lot of the new generation imaging people are looking at the equal to sign anywhere and commenting on it that there is an equal to sign. But like you very rightly pointed out, you need it at the base of the nose here for the equal to be classified as equal to. Otherwise, you can misinterpret as an equal to sign. That is the nasal bone, and that is the place where the nasal bone is supposed to be, but it is not there. So this is a case of hypoplastic nasal bone. But like Dr. Krishna Gopal had insisted in the previous cases also, we need to do a complete structural evaluation. So once we did a complete structural evaluation, the nuchal translucency was normal. There were no other abnormalities. The ductus venosus flows were normal. Tricuspid was normal. And taking care of all that along with maternal serum biochemistry, what happened was the risk for trisomy 21 actually reduced. So her background risk was 1 in 759, and that became 1 in 5,254, despite having an absent nasal bone. All other parameters being normal have tilted the risk assessment in the realm of normalcy. Now, Madhulika ma'am, how will you counsel this woman? She has an absent nasal bone, but a low risk for trisomy 21. Ma'am, unmute yourself, please.
Yeah, sure. So the causes of absent nasal bone, the most important ones would be the aneuploidies. And we need also to remember that about 2% of the normal population would also have an absent nasal bone or a hypoplastic nasal bone. So we have to keep this in mind, and then we are correlating the other biochemical markers and other features on the ultrasound. We need to tell them that this is a marker for aneuploidies, and then we can give them the option of screening for aneuploidies. So this screening for aneuploidies in an isolated marker, we can give them the option of getting a NIPT done. And in that situation, if that is normal, after that we can go ahead and do further testing in case they are interested in doing it, which could be an invasive testing. So here, because absent nasal bone, the most important aneuploidy would be trisomy 21 here, and that can be ruled out by NIPT.
But the patient asks you that my risk overall has come low, it is 1 in 5,000. Do I still need to test further?
Yeah, so it would again. So here again, we would have to tell them that in isolation, it would be a low risk situation. And we have seen other investigations. So entirely the testing choice would depend on them. We have to tell them that other than these aneuploidies, there can be some other causes also, which can be some microscopic chromosomal causes and all, which can cause hypoplastic nasal bone, and it can be a normal variant as well. So finally, they need to decide whether they want to go further or no. But to rule out common causes, doing NIPT would be a good option. But again, the parents have to find, the patients have to finally decide what they want to do.
So Dr. Vandana, this is low risk on FTS for trisomy 21, but there's a suggestion about doing cell-free fetal DNA, and there is a background possibility of other problems as well. Do you think cell-free DNA has a role here?
Yeah, I think a contingent approach to cell-free DNA works well for any soft marker that you find on ultrasound. So that always gives us an assurance that at least you've ruled out the bulk of the problem, which is trisomy 21. So my approach generally is that if I find an absolutely low-risk fetus other than a hypoplastic nasal bone in the first trimester, I call the patient back at the 16 weeks. At the 16 weeks, I kind of see some bit of a nasal bone or it starts appearing or I'm happy with what I see, then I do give them the option of QFPCR or doing nothing. And if I don't see the nasal bone again in the second trimester, then I do discuss option of cell-free DNA in the first scenario. And if I do not see the nasal bone at all in the second trimester, then I do discuss invasive testing also with them.
No, let us get this right. So first trimester scan she had, the NT scan, the nasal bone was not seen. The overall risk for Downs was low. At that point, you wanted to wait till 16 weeks. You did not do any testing at that point.
I think it's flexible. I can still give them the option of QFPCR even at that point of time because they always have
So
that.
if they want 100% confirmation, you would go ahead and do a CVS at that point only and do that. But the decision for CVS will depend on your auxiliary counseling because the actual risk that you have shown on the risk assessment thing is low risk.
Yeah,
but since you will still go ahead, which is something which I think all of us need to understand, that, you know, screening is a process where you may have false positives and false negatives. So if you want to make the best out of it and at least be clinically sound to your patient, you need to tell them that, look, statistics say that your risk is 1 in 5,254. But, you know, realistically, you are different from another woman with the same risk with a present nasal bone, whereas you are an absent nasal bone, and discuss all the options. Dr. Krishna Gopal, in your experience, how many times do you think that if the nasal bone is absent in first trimester, you've seen it being present in the second trimester? I think he's out at some time. Dr. Sumitra or Dr. Vandana, whoever does imaging.
The one point I'd like to make is it's technically challenging to see the nasal bone in the first trimester compared to the second trimester. It's definitely harder. You need a better machine. You need more expertise. And with all the obesity rampant,
let's not put that there, because what we are assuming is when we are doing a first trimester scan, we're doing it as per the protocol and assuming that we can see what is there. So if there is no nasal bone in the first trimester seen properly, I mean, we are not taking into account people who did not see it because they couldn't see it.
I won't be able to give you a percentage, but we do see fetuses.
That sometimes it comes. So Madhulika ma'am, I want to ask you, is there a difference between delayed ossification of the nasal bone and absent nasal bone overall?
Yeah, so absent nasal bone would probably be more indicative of an aneuploidy as compared to delayed ossification. And it has been found that if it is persistently absent in the second trimester, I mean, around 16 weeks, that the likelihood of an abnormality like aneuploidy is higher.
But if at 16 weeks you see a nasal bone, you would actually feel reassured, or you would still be worrying about aneuploidy?
So the risk would definitely go down, because it was probably a delayed ossification, but the risk doesn't go totally. But then the risk would definitely go down if you're seeing it at 16 as compared to
So in nutshell, we cannot forget the fact that there was absent nasal bone in the first trimester. It is going to haunt us, and therefore we discuss all the other possibilities. And like you said, since Down syndrome is the major concern that we have, cell-free DNA will help us rule out Down syndrome. But if the patients want a more detailed investigation, then an invasive test with a microarray.
So here, there is nothing like black and white. So there are many gray zones. But
no, I think that's something very true, ma'am. Like you are not speaking just like that. You are speaking as somebody who has worked so many years in this field, and you are an academician. You understand the value of evidence. Yet you feel that it is important for you to tell the patient.
It will also help if you rule out the
communicate to the family that what are the possibilities, and at the same time reassuring them that the risk is not as high. I mean, if you have other things normal. But then the ultimate decision after understanding has to be taken by the couple.
Now, this particular case, they went ahead and had an amniocentesis after the counseling. And in the microarray, what was found is an abnormal copy number variant. And this is not something we were looking for in the first place, because what we thought of, if we do a cell-free fetal DNA and we find no Down syndrome, we would be able to rule out bulk of the problem. So maybe we were sheer lucky in this case that this is the case which went in for a microarray, and this is the case where some abnormal thing. But suppose we had done a cell-free DNA and that was normal, and then probably later on we could have found some association of these problems that could. So as a clinician, like Madhulika ma'am said, there is nothing black and white here. You have to give many options to the patients and support it with your own experience as well as what evidence says. Because see, at the end of the day, statistics are for populations. For the individual, it's the outcome which matters. And if that particular individual is willing to go that long distance and get the tests done which are required to reassure them completely, I don't think we should back out from offering that to our people, especially when they themselves are paying for their tests. So that's
Dr.
one
Chinmay,
thing.
just wanted to add that there is a challenge which I face coming from a government setup is the cost, because my patients and then the turnaround time with NIPT, the cost, and then you are, again telling them to go in for invasive. So sometimes that is a big challenge, and then the patients would opt for a invasive because
which is fine, ma'am. See, whatever works best for your patient. At the center of the care is the patient, and your purpose as a fetal medicine specialist is to offer them a healthy fetus, a healthy baby at the end of the day. So within your circumstances, whatever is available, that is what you will offer them. And I think we have to all make our own protocols which suits our own organization, and give the patient the option of even taking a care elsewhere if they have, because we cannot go beyond our organization. We have to work within our organization protocol. So now once we have identified the copy number variant, now what? Dr. Sumitra, you can answer that. Like already.
Well, the parental, So the parental array should be done, because you have to then look for the same, and whether it is just a VOUS or
now I'm with all respect to all the eminent geneticists here, as a clinician, you know what happens? The box just keeps opening one after the other. So it never stops. When do you think I can put a full stop on this and say that, okay, that's it, now nothing more can happen?
I think Madhulika ma'am would be able to add to that.
Okay, so now this is a very interesting case, Chinmay, actually. And I don't think absent nasal bone really correlates with the phenotype. It was just by chance that this was found. And I had never seen a case on this, so I actually read up about this. So it is a well-known microduplication syndrome. And as you have written in the slides also, the phenotype is very variable. It is a subtle phenotype, autism, some developmental delay, hyperactivity, slightly large head, and increased growth, and so on and so forth. Though there are rarely some other phenotypic features which might be picked up on ultrasound have been described, like a congenital heart disease and club foot, and so on and so forth. So now in this situation, when you are getting an abnormality in the copy number variation with a known phenotype. So the phenotype here is known, right? And again, as Sumitra said, testing the parents would be a good idea, because the parents might be having it without having overt manifestations. That is true. And again, as the same way I said for Noonan, here also the phenotype may be absolutely subtle. So mild behavioral problems, some subtle autistic features, slightly large head, all these can actually be missed. So variable phenotype may be there. Now, in this situation, I think the father also had the same variant, and they ultimately decided to terminate the pregnancy. So again, here we have to tell the family that what is the likely phenotype. And again, we are lucky here that we are getting something definitive. I mean, if we get something like a VOUS, as Sumitra was saying, that the things becomes very difficult.
My question, ma'am, as a clinician, how can you call it definitive when there is an adult with that thing who doesn't have problem?
Right. So that's what I am saying, that it is the mechanisms for the father is having the same, and he is apparently normal, though he has to be evaluated very carefully. So why it happens that somebody is harboring, say, a microduplication or a deletion and is not manifesting, and we can imagine that maybe the fetus when grows will have a phenotype. So it is very difficult to tell that what kind of a phenotype the fetus is going to have, and this would depend on other associated changes in the genome of
I'd
the
make
fetus.
a point here, ma'am.
Yeah,
I mean,
yeah.
we are getting carried away with the genetic part of it, which is your expertise, but we are talking to a group of obstetricians. You know, the questions we face is, madam, should we terminate? Should we not terminate? Now,
Okay.
as I said, point number one, definitely put the geneticist in the loop, if not for anything else, just to share the responsibility of that decision. And that decision has to be documented. Like Madhulika ma'am said, the decision for terminating is never the clinicians. It is always based on the parents, but supported by information that we are giving the parents. However, at the end of the day, suppose, ma'am, they opt for termination and later on they have problems conceiving again, or they have a broken family or something, and this goes to litigation. Medico-legally also, we need to cover ourselves by documenting all these things, documenting the inaccuracies and documenting the insecurities of both the parents and the clinician, so that this decision was not taken in haste. Because in real life, these are the problems which will later come on. Suppose 2 years later, you discovered that, okay, this is no more pathogenic. We have now seen enough number of cases who are good, and there is a publication which says this is no more abnormal. And then they come back with that. So we should do that. Current genetics at this level, it is classified as such, and so we have taken it.
So we have to tell them what information is available as of date. So that's another very important thing, that we have to go back and check and read up and then counsel them. Tell them the phenotype which is available as of now. Tell them that there is a high possibility that the fetus might not have significant problems, as the father is harboring the same variation and he's asymptomatic. Okay, but also tell them the possibility that because of the some associated genetic changes in the fetus, the manifestations may be there, and the manifestations which are described are these, which could be as subtle as maybe some behavioral changes or mild ID or something like that.
The only challenge is that in an unborn fetus, anything you say raises a lot of suspicion in the parents.
Yes, I
and
understand.
That I think
and
we
they
have to
tend to
handle.
terminate. They
so
tend
that
to
is
terminate.
So there's no excuse for that. As clinicians, if we are in an age where this kind of information is evolving, we have to educate and empower ourselves to counsel people properly.
Definitely. And it has to be very clearly documented, Chinmay, as you have said, on the records which we give to the family. Maybe a nice typed document would be of great help.
True.
And
so
50%
this is a real important take-home point for all obstetricians, because you'll be seeing these cases more and more. All kinds of genetic reports we are getting nowadays, thanks to the number of labs who are doing stuff and this ability to ask for a lot of tests. So please counsel in conjunction with a geneticist and document it. Akshata, take the next case, please. We have now only 10 minutes left.
Yes. So a quick discussion. So this is OPD, and you have this report right in front of you. And if you see here, you have your reports. What are the risks here? Is this a high risk, or is this a low risk report? Dr. Sumitra, could you please help us interpret this report?
Yes, Dr. Akshata. So this, if we look at the serum markers and we see the moms, the beta HCG is at 3.7, and the papa is 0.9. Yeah. So the combined. So let's look at the combined, because the detection rate is highest with the combined. So with NT plus the papa A plus the beta HCG. So if we look at that risk, that comes to 1:248, which the background risk was 1:415, the a priori. So the risk becomes higher. So she's coming into the, if you look at the GCPR FOXY guideline, 1:250 is high risk. So she's definitely in the higher risk. But if we add the other ultrasound markers, because mostly, Dr. Akshata, the reports are coming as the combined ones only.
Right.
But if we add the ultrasound markers, that kind of lowers the risk. So I suppose the DV and the TR, yes, and then the intermediate
wants to make,
so it is coming in the intermediate risk category. Then I would say 1:5.
Right. So if you see, if you're looking only at the biochemical risk, you're getting a high risk. So you have to decide what high risk for your screening population. Certain centers may use a risk of 1:250. Certain centers may use a risk of 1:150. It will depend upon what practice you have. For a center that uses NT, TR and PAPE and beta HCG, the cutoff that you may use, because you are very sensitive, the cutoff that you may use is 1 in 150. However, for a center that you're using just an NT and a PAPE and a beta HCG, which is still a combined test, your cutoff may be 1 in 250. So like you rightly said, Dr. Sumitra, here, if you're just looking at the ultrasound parameters, your risk is 1 in 5,000, which is giving you low risk. But if you're looking at NT plus bloods, is the last one here, that is the combined test. This is the most sensitive one. It is 1 in 248. So what will you do? What would you like to do next, and why? Dr. Vandana, what would you like to do in this situation?
Shweta, move the text of your slide. Put on all the text.
So if, a good plan, again, as we've already discussed, if we have an intermediate kind of risk in any screening, cell-free DNA works as a contingent plan for us very well. So I would say if the risk is high, say greater than 1 in 100, which 5% or so of our population would be, we would discuss the invasive testing more thoroughly with them. And only if they don't want that would we go for a cell-free DNA option. Anything intermediate risk, which is between that and 1 in 1,000, we can always discuss cell-free DNA options with them. And anything which is low risk, we can leave alone. So here I would be comfortable offering her the cell-free DNA option with these kinds of risks.
Because the ultrasound was normal and she had intermediate risk. In your protocol, it would be that you would offer her an intermediate risk. Suppose this age risk was 1 in 1,500 and the adjusted risk was 1 in 1,200. What would you do in such a situation?
1,200.
1 in 1,200, sorry.
With the 1 in
move on the text of your slide. Bring the whole slide.
With the 1 in 1,200 adjusted risk, I can leave her alone also. Because it's a low risk pregnancy and I don't need to screen her further for Down syndrome per se. So I think I just do routine obstetric management and not really bother about any more screenings. It's the intermediate risk where I'd offer a cell-free DNA.
Right. So there are two ways of looking at it. One is the adjusted risk higher than your age-related risk. That is one protocol. If the adjusted risk is higher than your age-related risk, you may want to investigate further. And in that case, you may want to offer a cell-free DNA. The second protocol that we can follow, which is also the FMF protocol, is that if you're having a high risk for your unit, in our unit, for example, we use 1 in 150, we would offer her an invasive. If it is an intermediate risk, like Dr. Vandana just said, we could offer her a cell-free DNA. And if it is a low risk, we would offer her an expectant management. So like you said, it is a contingent testing that we would like to do, because this would decrease the invasive rate and it would improve our detection rate. So here the cell-free DNA was done, which was high risk for trisomy 21, and an amniocentesis was done, and the fish was suggestive of trisomy 21. So any comments, Dr. Krishna Gopal, as to what is the sensitivity and accuracy? Which is the test that we should actually look at? Just the bloods? Should we do a quadruple? Should we just look at the first trimester screening? Dr. Krishna Gopal?
Unmute yourself, please.
Okay, so basically, sensitivity and specificity is defined in the terms of detection rate and the false positive rate. So the best result is by the combined test, then the nasal bond, DV and TR, and it has a detection rate of 93 to 96%, plus false positive rate, that is 5% with the combined test, that goes down to half. That is the 2.5%. So this is the best test that we can offer. In the second trimester, as few pregnant females is still present in India in the second trimester, we have the best option with the quadruple test, that has a detection rate of 70 to 75% with a false positive approx 5%.
Yes, so the take-home message here would be that combined test is the basis of screening in the first trimester, unless the patient wants to go in for a cell-free DNA, which is more accurate. but we would like to look at the anatomy. So a first trimester screening combined test. If at all she's missed her first trimester screening, is when we would offer a quadruple test in the second trimester. If you've had a normal first trimester test and you are offering her a quadruple test, be sure that you have the software to integrate the quadruple test. There's no point in doing a quadruple test separately in the first trimester. You're not going to integrate it. So agreed that doing a quadruple is going to improve your detection rate, but you should know how to integrate a quadruple test. What will be your a priori risk when you're taking a quadruple test into consideration? So that is what one must remember. A quick slide on the fact that suppose you have a patient in which you're just doing a biochemistry for a background risk of 1 in 884, and then you keep on adding NT, NB, DV, TR, and various markers. With addition of every marker, you're going to improve her risk assessment and you're going to bring down the false positive rate. So just do not look at only biochemistry or only NT, unless of course it is an increased NT where you might want to go in for a direct invasive testing, but always look at all the markers together, at least an NT and a PAPE beta HCG. Role of placental growth factor has come up in a big way now for prediction of preeclampsia, and it's called as the enhanced first trimester screening, and most fetal medicine centers are offering it universally, and it adds about 2 to 3% for detection of Down syndrome. So this also could be done for preeclampsia screening. Right, Dr. Chinmay, would you?
Like you said, individually, every marker should not be given that much of an importance, but we always look at it in a combined way and get a consolidated risk assessment. So in this case, it's a little different from the previous ones because this is a twin pregnancy. And in the interest of time, I'm just going to move in quickly that the moment we say twin pregnancy, how do we go about doing a risk assessment? Dr. Vandana, what would you think? I mean, this is a twin pregnancy. How do I have done a scan. I have found 2 different NTs. How do I give risk assessment in this case?
Yeah, so one, I would like to specify that we should always mention DCD or MCDA twins.
So chorionicity. So first point is chorionicity. Dr. Krishna Gopal, what is the best way of assessing chorionicity in twin pregnancy?
We must suspect it in the early pregnancy, but we must diagnose and assign it by our first.
So what will help you assign chorionicity in the first trimester scan?
The best is our mathematical T sign and the
lambda or the T sign, so that you look at the interface of the membrane with the placenta, and if you see a rising chorionic sign there, a twin peak sign, then you know that is dichorionic. If you don't see that, then it is monochorionic. So first and foremost, chorionicity has to be established. And Dr. Sumitra, why is chorionicity so important for risk assessment?
Dr. Chinmay, I think we'll have to wind up quickly.
Yeah, so chorionicity is very important because if it is monochorionic, we will think that both of them should have the same risks. If it is dichorionic, both of them should have different risks. Now, one of the most important things that I want to say here is, would you be happy to do biochemistry in a twin pregnancy, Dr. Sumitra?
Well, yes, biochemistry would be for twins. Yes, the biochemistry can be done.
But only biochemistry.
However, only biochemistry is not of good. It has to be integrated with the NT. And so in a dichorionic, the individual NTs can be taken, and in a monochorionic, the average NT.
Average of the NTs is taken, so that only one risk assessment is given. Suppose it comes as high risk or intermediate risk, right? Like we discussed in the past, there is a role of doing NIPT in these cases also, although evidence is still emerging about how sturdy it is, but it can be sometimes used to rule out Down syndrome actually. If it comes doubtful, you may still have to do an invasive. And since Dr. Aparna is like very strict about timings, we won't be having much time to tell this. So I'll just go on to the take-home messages here, that establish chorionicity, do a scan-based assessment first. And then if you want to add on biochemistry, it has to be in combination with the scan. And in monochorionics, both will have the same risk. And in dichorionics, they'll have individual risks. Anytime there is a doubt, we will move on to invasive for both the babies, or cell-free DNA as an intermediary necessary just to rule out false positives here. So I think we are ready to kind of wind out this thing. There was a question that whether we could take in intracardiac echogenic focus for discussion. That would come in the second trimester. So I hope AOGD gives us an opportunity to do second trimester screening sometimes when we will do the genetic sonogram in detail, because that is yet another chapter in itself. So before we wind up quickly, Dr. Aparna, allow me to take one take-home messages from our esteemed panelists, because they are experts in their field. Dr. Krishna Gopal, what would be your take-home for this panel?
The first trimester screening and the ultrasound is the base. We must do it correctly, and at the same time, we must interpret it correctly.
Absolutely. So doing it correctly and interpreting it correctly. Perfect. Dr. Sumitra?
I think the cell-free DNA to only be offered as part of the contingent screen, not as a universal screen. And especially to emphasize that it is only for the detection rate is 99 and above for T21. For 13-18, still we need to counsel because the detection rates are lower.
Dr. Vandana?
I think it's the clinical background of the patient which helps us decide which test is valid for which. So we have to tailor make it to the particular patient and situation and not use blanket tests to do any like cell-free DNA for everybody or etc. So try to tailor make it to your particular situation.
So don't use universal guidelines all the time, but look at the patient in question and do that. Perfect. Dr. Madhulika, ma'am, final words from you.
Yeah, for me, I think the message would be that we have many advanced technologies available now to test the fetus when we are doing invasive testing. But before offering any such test, it is extremely important that we ourselves understand that what is the outcome we are thinking of, and the family should be counseled very, very properly about the possible yield of the test and the uncertainties and the costs which are involved in such tests. So taking these tests, they are very good, they may be very conclusive, but there's a high chance that they may be inconclusive. So before taking any of these tests like microarray or exome in a fetus, I think we have to be extremely cautious and
do a very good pre-test counseling before,
yes,
so that they know what they
counseling and
out of the
document
results.
everything, whatever you are doing. I think that is very, very
Dr. Akshata, you have looked through all these cases through a fine-tooth comb. So please summarize the final take-home points for everybody.
Yes,
and then
I think, like everyone said, contingent screening, multidisciplinary care. For us, although multidisciplinary care would mean the obstetrician, the fetal medicine, and the geneticist all together, because a good history taking is important so that the obstetrician sends it to the fetal medicine person. A good scan and a good interpretation of the findings is required so that we further refer it to the geneticist. And that's when we are really going to take care of the entire pregnancy. So thanks a lot.
Thank you very much for this opportunity. And I think we are within time and we are closing now. Thank you very much, expert panelists. We had a very good
Thank you very much.
Thank you. Thank you.
Thank you all of you.
Thanks.
Over to you, Dr. Aparna.
Yes. So thank you, Dr. Chinmay and Dr. Akshata and the esteemed panelists. And I think it's been a brilliant session, and it's really a pleasure to hear Dr. Chinmay, Dr. Akshata, and all the panelists, because, the insights that you people always give, it's always, we always learn something new. So thank you, everyone. And especially thank you for finishing this on time with so many messages in between. So now we move on to our next session, which is a brief inauguration, because, we have put together this program, and it is never enough. We cannot begin without thanking. So very good morning to all, and I feel privileged to extend my warm welcome to all the faculty, colleagues, delegates, and my dear friends who have joined us for the AOGD post-conference workshop. To begin this, I invite Professor Vatsala Didwal, professor in the Department of Obstetrics and Gynecology at AIIMS, New Delhi. She's a brilliant clinician and very enthusiastic leader with a charismatic personality, and also the convener of this workshop. I request ma'am to deliver the welcome address.
Good morning, everyone. It's my proud privilege to extend a warm welcome to all the faculty and delegates for this workshop. And definitely, I extend a warm welcome to my guests for the inaugural session. So I welcome Dr. Sunesh Kumar, who is the convener for the workshop, head of the department at AIMS, and Dr. Neeja Bhatla. Everyone knows ma'am, the ever smiling Dr. Neeja, who is the unit head, Department of Obs and Gynae at AIMS, and Dr. Mala Srivastav, senior consultant at Gangaram Hospital and the president of the AOGD, who is responsible for this successful endeavor of virtual e-conference. So we have taken this opportunity, thanks to Dr. Gangaram team, to hold this workshop on fetal medicine. So we have looked at the care of fetus in its journey across the various trimesters, and we have tried to deal with common problems which are there in day-to-day clinical practice, like how to interpret a screening test, aneuploidy screening, how to manage growth disorders in singleton and twin pregnancy, and also had a small kind of a journal club to update us on the recent advances. And to break the monotony, we have introduced a new way of discussing cases, a quiz. So let's see how that works out. Again, I would like to thank all of you for joining in, and I really thank my guests who have joined us for the inaugural session. Thank you.
So thank you, ma'am. And light is a symbol of brightness and prosperity. So let us now light the ceremonial lamp to make this morning a blessed one and to seek the blessings of Goddess Saraswati. So may I now have the Saraswati Vandana.
Kurutvam kalyanam arogyam dhanasampada shubham kurutvam kalyanam arogyam dhanasampada shatru buddhi vinashaya dipajyotirnamostute dipajyotirnamostute shubham kurutvam kalyanam arogyam dhanasampada Shubham kurutvam kalyanam arogyam dhanasampada.
I consider it a great honor and take this opportunity to invite Professor Neerja Bhatla, Professor and Unit Head, Department of Obstetrics and Gynecology at AIMS, New Delhi. Ma'am is a visionary with a passion for knowledge and teaching. She is an acclaimed and internationally acclaimed gynae oncologist known for her work in preventive oncology. She is also a brilliant administrator who believes in teamwork and taking people along the way. Ma'am, it is my honor to welcome you here today and would request you to say a few words.
Thank you, Dr. Aparna. Thank you very much. It's indeed a pleasure to be here at this first of the post-conference workshops. And I am really, really proud that our team in the Division of Fetal Medicine is not only doing excellent work, but they are also excellent teachers and organized a wonderful workshop. Fetal medicine is indeed a growing specialty, and every couple wants to have a healthy and normal baby. And it's not only just important for the family, it's important for society at large that we have healthy babies. So I'm really happy also to see the interest in this specialty and the growth countrywide, which has been enabled by the Society of Fetal Medicine. And I wish you all great success for your workshop and for your endeavors thereafter.
Thank you so much, ma'am, for your kind words. And it is now my honor to invite Professor Sunesh Kumar, Professor and Head, Department of Obstetrics and Gynecology at All India Institute of Medical Sciences, New Delhi. Sir is also the convener of this workshop. Sir is a gynae oncologist par excellence. He is also a legendary teacher and a dedicated clinician who is known for his unwavering commitment to his work and his patient, which inspires an entire generation of students and teachers likewise. I invite you, sir, to say a few words to inspire us all.
Thank you, Dr. Aparna. Dr. Mala, who has been so busy and has done a wonderful job in organizing this first conference in e-mode. I welcome all the seniors, delegates to this workshop. being organized by the Department of Sangaini in the specialty of fetal medicine. I welcome my colleagues, Dr. Nirja Bhatla, Dr. K.K. Roy, and other faculty who are behind organizing of this conference. I remember since the first IoT which I witnessed at AIMS in 1987, we have gone a long way since then. In my department, roughly about 600 intrauterine transfusions have been done so far. And over the years, we have developed a great specialty which is being used by patients. We also got an opportunity to start a fellowship course in fetal medicine for last 4 years, and we are happy to see a number of people who joined this course are now in various institutions. I am sure this is one specialty which will keep expanding, and hard work being put by my colleagues, Dr. Vatsala, Dr. Aparna, Dr. Anubhuti, and other faculty is of great immense importance to the obstetrics and gynecology. I once again thank the organizing team for organizing such a wonderful activity, and I wish at the end of this activity it increases your horizons and knowledge. Thank you.
Thank you, sir, for your encouraging words. It is now my privilege to invite our chief guest, Dr. Mala Srivastav, our dynamic president of HOD of AOGD from Gangaram Hospital. Ma'am is a gynae endoscopic and robotic surgeon. She, along with her team, has put forward this brilliant, never before super successful, meticulously planned AOGD conference, the first ever virtual AOGD conference. It is indeed an honor to have you with us, ma'am, and we would like you to say a few words of encouragement.
Thanks, Dr. Aparna. Good morning, everyone. It's my pleasure to be a part of this workshop on fetal medicine, care of fetals across all trimesters. The program is nicely planned by Dr. Sunesh Kumar and his team, Dr. Vatsala, Dr. Aparna, and Dr. Anubhuti Rana. We should have focused deliberations on different topics of interest, and fetal medicine is one of those most sought after branch of obstetrics, which is growing now in leaps and bounds. We are happy to see national experts from different parts of the country who is participating in this conclave. I can see Dr. Chinmay Ratha, I can see Dr. Madhulika Kabra, and all senior faculty members from all over the country who is participating in this huge e-conclave of fetal medicine. This program deals with the various aspects of the care of the mother and the fetus. I wish all the success to this workshop, and I hope all the young delegates, postgraduate students, residents will take a benefit of listening to the star speakers and the galaxy of panel discussions, and they will definitely benefit at the end of the day. I hand over the proceedings to Dr. Aparna to carry on the today's scientific deliberations. Over to you, Dr. Aparna.
Thank you so much, ma'am, for your kind words and your gracious presence here. I would now like to propose the vote of thanks on this virtual platform. At the outset, I would like to thank Dr. Mala, ma'am, and the entire AOGD team for their untiring efforts and immense supports in the organization of this workshop. I extend my heartfelt gratitude to Professor Sunesh Kumar for his constant support and guidance. I would like to express my sincere gratitude to Professor Nirja Bhatla for her gracious presence and inspiring words, and Professor K.K. Roy for being here today on this platform. A special thanks to Dr. Vatsala Redwal for her remarkable efforts and leadership since the inception of this program. I would also like to thank our co-conveners, Dr. Anubhuti and Dr. Rinchan, for all the help in organization. My sincere thanks to all the eminent faculty and moderators and chairpersons and panelists. The scale of this program has been possible because of the enthusiastic support of all these distinguished faculty. I also thank all the delegates for their active participation in making this huge event a huge success. And I thank you all for being with us. Now, with this, we carry on and go to the next session, which is from consensus to controversies. And I'm sure this is going to be a very interesting session with two great speakers and two chairpersons to carry on this session very successfully. So we hope to have your continued presence with us till 1:30, and we promise you to be on time and also provide you with much interesting material for your knowledge, and also at the same time continued increase in knowledge. Thank you so much. So Anubhuti, please. Yes, no. Can I request Dr. Anubhuti to please take over for the next session? Thank you, ma'am. Moving to the next session, from consensus to controversies, I'm glad to invite the esteemed chairpersons for this session. Professor K.K. Roy, sir is professor in Department of Obs and Gynae, AIIMS New Delhi, and Dr. Jyoti Meena, associate professor, Department of Obs and Gynae, AIIMS New Delhi. Yes.
Good morning, everybody. And my privilege to introduce the first speaker. You all know her. She is Dr. Sangeeta Gupta.
Because you don't have a lot to do with this. How are your panelists?
Okay.
So I present before you the eminent speaker you all know, Dr. Sangeeta Gupta. She is Director Professor in Obstetrics and Gynecology, Maulana Azad Medical College, New Delhi. She has already established fetal medicine unit and a clinic at MAMC and LNJP Hospital, New Delhi. She has a vast experience in invasive procedure. She was awarded Commonwealth Scholarship in 2007, trained in fetal medicine in St. George's Hospital, London, faculty of F&B training program, high-risk pregnancy and perinatology, multiple publications and contributions to various textbooks. She's a member of Fetal Medicine Subcommittee, AOGD. She's the editor of AOGD Bulletin 2016-17 and Joint Secretary AOGD 2010 and 2011, and executive member of the Society of Fetal Medicine. With these words, and may I invite Dr. Sangeeta Gupta to deliver her lecture. Thank you.
Good morning, everybody. I would like to thank AOGD team for giving me this opportunity, and particularly Dr. Vatsala and Dr. Aparna. And I would also like to thank Dr. Roy for his kind introduction. So I'll share my slides now. Are my slides visible?
Yes.
Yeah. So today I'm going to talk of consensus to controversies. And for that, the topic which I have picked up is preeclampsia. And with the magnitude of this disease in obstetrics need not be elaborated. It has serious and long-term consequences both for the mother and the fetus. So what we have reached a consensus about screening of preeclampsia. Definitely it is a disease which can be screened and prevented. And after this publication from Fetal Medicine Foundation, we all know that the performance of the Fetal Medicine Foundation triple test, which includes the mean arterial pressure, uterine artery PI, and the biomarkers like PLGF, the performance is as high as 90% pick-up rate at a false positive rate of 10%. And of particular importance is this bar where we are going to pick up 75% of the preterm preeclampsias, which is the most important group. And we can see how we have increased this from 45 to 75 when we only use maternal factors for screening. The other thing which has come up in a big way is aspirin prophylaxis, which is the holy grail for prevention of preeclampsia now. And this is a small chart which traces the history of aspirin to way back in 1500. At that time, also people knew the anti-inflammatory and anti-pain relieving properties of aspirin. Willow tree leaves were used for relieving the pain. And then the landmark study in 1978, when first case where aspirin was used for prevention of preeclampsia, and it was successful. And later on, we had the CLASP study, and then we had this in 2013 we had the cell analysis which showed the effect of preeclampsia aspirin on how we can bring down the rates of preeclampsia by just by doing the screening. And then finally in 2017 we could establish that through the aspirin trial that there is 62% reduction in preeclampsia once you start aspirin in a particular high risk patient which are screened between 11 to 14 by the triple screen method. So this is the landmark study of aspirin trial. And now moving from consensus to controversies, here I will be covering it in two different parts. Though aspirin has been established as a very good modality of prophylaxis for preeclampsia, but there are certain controversies which have cropped up with such a beneficial effect of aspirin. And the second aspect which I'm going to cover today is the angiogenic markers in twins and preeclampsia prediction. So first, my background paper will be this expert review, which has recently been published in the American Journal of Obs and Gynae in 2020, which has talked in detail about the prevention of preeclampsia with aspirin. So for getting the 62% reduction in preterm preeclampsia in the aspirin trial, it was only possible with a good adherence to taking the pill by women. And this results were there when adherence of 85% was seen, and this was observed in 80% women. So the message I want to give here is that adherence to therapy is very, very important to bring down the incidence of preeclampsia by using aspirin for prophylaxis. Now you can further reduce the incidence of preeclampsia to 76%, provided the adherence to the treatment is increased to 90%. And there can be a further reduction of 90% has been observed when it was used in high-risk women where there was no patient with history of chronic hypertension. This means that patients who have pre-existing chronic hypertension, though they have a very high risk of superimposed preeclampsia, but they are not probably the right candidates which will have any effect of this kind of a preventive effect of aspirin. Now, there were concerns about the side effects of aspirin, like congenital heart defects and structural defects, but a lot of studies have brushed them aside, have proven that they are not significantly increased. However, a recent publication in 2018 has raised concerns about cerebral palsy, where the children who had cerebral palsy, their mothers were interviewed, and they were asked if they had ever taken aspirin in the pregnancy. So now what is the criticism of this or the limitations of this study is that what was asked was ever used. And there was no account for what was the dose used, what was the frequency, the timing, and the indication of aspirin used. Of course, there was a recall bias because things were of the past. And moreover, it did not adjust the analysis for preeclampsia, preterm birth, and SGA neonates. All three of them would in themselves contribute significant to cerebral palsy. There were again concerns about hemorrhagic complications of aspirin. And the trials like CLASP and aspirin have shown that when aspirin is given in a targeted high-risk population, there was no difference observed in either neonatal intracranial hemorrhages or postpartum hemorrhages. And there has been literature which has said that these increased risks are seen in patients when aspirin prophylaxis is used universally even in low risk population. Again, another concern is of placental abruption. Now, as far as placental abruption is concerned, this association was found when aspirin use was started after 16 weeks and not before 16 years. The plausible explanation is that late initiation of aspirin prophylaxis in women with impaired placentation doesn't help because placentation is completed almost by 16 to 18 weeks, and this may lead to an increase in risk of placental abruption. Now, what are the limitations of aspirin in prevention of preeclampsia? So, as I've already discussed, a woman in whom there is a woman who's already having chronic hypertension, there was no significant reduction in superimposed preeclampsia observed, and the probable things was a pre-existing endothelial dysfunction or a pre-established suboptimal cardiovascular function. Now, this is another systematic review published in 2016, which talked about prophylaxis of aspirin in for preeclampsia in multiple gestations. So here I would like you to concentrate on this chart where there was a significant decrease in preeclampsia and mild preeclampsia, but there was no significant decrease with use of aspirin in severe preeclampsia in twins. So the conclusion being that if you cannot decrease severe preeclampsia, then probably you are going to not have a significant impact on the morbidity of preeclampsia. And the limitation of this study was the small number of patients in which it was initiated before 16 weeks. There are concerns about effect of future cardiovascular morbidity of the mother. We all know that as women who have high preeclampsia have a higher incidence of hypertension in future and even cerebrovascular and cardiovascular events later in their life. So there is a debate about the protective effect of this aspirin taken in pregnancy. They say that it could have a beneficial effect if we presume that preeclampsia is caused by impaired placentation. However, people who propagate that it is the suboptimal cardiovascular adaptation in pregnancy, here aspirin may not be beneficial if you take it for a short period during the pregnancy and is unlikely to modify cardiovascular events in the future. Now, the idea of discussing all this background about aspirin was that it is such a wonder drug, such low cost, good benefits, and a high safety profile. It has given ideas to people to use it universally because in low resource setting countries, it is very difficult to establish this type of an expensive and complex screening model and to deliver it to a whole population. Moreover, the proponents of universal aspirin prophylaxis are also uh, 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 they also say that prevention of FGR, preterm and stillbirths would be occurring simultaneously. So now the concerns about applying universal aspirin prophylaxis are that once you give a drug universally, there may be poor acceptance, which was also observed in the studies where aspirin was given for trial purposes. Many women had refused to participate in the trials where they were given the option, where they were offered, they were asked that if they would be ready to take aspirin or not. Secondly, whenever there is a universal application, poor compliance is another concern. And we all know that if the compliance falls to less than 50%, probably there would be no reduction in preeclampsia. So when you do a high-risk screening, you counsel a woman one-to-one, probably her compliance is expected to be more. And of course, increased hemorrhagic complications. However, all the benefits of or the risks of a universal aspirin prophylaxis, as well as the feasibility of this model, needs to be evaluated thoroughly in randomized controlled trials. Moreover, the cost effectiveness studies have also shown that universal aspirin prophylaxis is going to be much more cost benefit, much more viable and very less costly as compared to this high risk screening model and doing a screen and treat modality. However, when the cost is calculated, the factors which should be considered are shorter stay in neonatal intensive care units, which outweigh the screening cost, long-term consequences of women who are likely to develop hypertension and cardiovascular effects, and lifelong morbidity for children who have developmental delays in the early years of life and later on folds. So with this, I come to the next controversy where we are going to, this is a recent systematic review which has been published in the Journal of Clinical Medicine in January 2020. And they have evaluated the role of angiogenic factors in risks in twin gestations and the risk of preeclampsia. So this in this search, which was performed till 23rd of October 2019, 10 studies were included ranging from 2010 to 18. So the first outcome which I'm going to discuss here is the difference in serum concentration of SFLT1 and PLGF between singletons and twin pregnancies. And out of the 10 papers, 7 papers were analyzed which had analyzed this parameter. And it was seen that both SFLT and PLGF have a higher level in twins than in singleton pregnancies. So it means that we need to develop reference ranges for twins for SFLT and PLGF levels. And I will be, and now there is a publication which has come from Hein Ran, who has developed a reference range specifically for dichorionic twins for PLGF. Now, we next are going to discuss the serum concentrations of SFLT1 and PLGF in monochorionic and dichorionic twins. So only 3 studies qualified for this correlation, and 2 of them reported no significant difference of these 2 markers between the 2 types of twins. However, Francisco et al. Reported that higher PLGF level in dichorionic twins that did not develop preeclampsia in comparison to singleton pregnancy, but he did not observe any such difference in monochorionic. So there is a lot of heterogeneity in results, and there is a limitation of the data available from this prospect. The third important parameter which was evaluated is the difference in serum concentrations of serum FLT in non-preeclamptic twins and preeclamptic twins. So 6 studies qualified for this parameter, and out of the 6 studies, 5 reported that there was a significant higher level of serum FLT in those mothers who developed preeclampsia, and this was seen across all 3 trimesters. But Bocuronian et al. Observed that this difference was only significant in the second trimester, but not in the first and the early second trimester. Whereas Shanzen et al. Reported differences in twins who had conceived by ART, but not in those who had conceived spontaneously. So you see how many issues are coming up when we discuss twins: the chorionicity, the method of conception. Now, what about PLGF? 9 studies qualified, and 7 of them reported that lower PLGF were reported in preeclamptic twins. And this spanned across all the trimester, particularly from late first to early third trimester. Now, last of all, I'm coming to the SFLT PLGF ratios, which has become a very popular diagnostic tool, particularly in the late pregnancy, to rule in or rule out preeclampsia. And the cutoff for this only 2 certified. The cutoff ratios, which have been validated in singletons, probably cannot be used in multiple pregnancies. And this is shown by the data by Rana and Droge, where they have shown that the cutoff of more than 85 does not apply to multiple gestations. Whereas Saleh has shown that a ratio of less than 38, which rules out preeclampsia for next 1 or 2 weeks, is not applicable to rule out preeclampsia in twins. So the limitations of this study were that multiple gestations were included, but they were not all restricted to twins. Some of them were higher order multiples also. And not enough data was available between monochorionic and dichorionic pregnancies. Now, this is a recent publication in the BJOG, which has just come up, I think, in September 2020, yes, where Hayes Ryan has validated a reference range of PLGF in twin pregnancies. And he has said that PLGF levels in twin pregnancies differ between those pregnancies that will later be complicated by preeclampsias and those that will not be, and they're independent of gestational age at the time of sampling. So this paper probably helps us to say that PLGF can become a very good method of screening for preeclampsia in the early pregnancy also, but we need to validate it. We need to do further studies as well. So to conclude, I would just say that aspirin, though it has come in a big way for prevention of preeclampsia. There is a good body of evidence to support it. But there is again another controversy which has arisen is that can we give it to all women? And we need to do further trials to answer these questions. Second, as far as preeclampsia and twins are concerned, we are in an abyss, a deep hole with no light. How to screen, what reference ranges to use, what model to use, what prophylaxis to give, and the impact of things like chorionicity and ART. So I leave you to, we all have to wait to get these answers. And with that, I thank you all for your patient hearing.
Thank you, ma'am. Thank you, Sangeeta, ma'am. You have very beautifully touched upon a very important topic, preeclampsia, which we are seeing in our day-to-day practice also. And definitely there are many controversies in the screening and the prevention part of preeclampsia. Uh, so I would ask any audience if they want to ask any question from Dr. Sangeeta. Yes. Yes,
Yeah, it was an excellent presentations, particularly this area controversy regarding aspirin. And you are very right that till the further evidence comes, we cannot just take it that we can give it to all women. Two areas are very important where it is established, as you said, is the prevention of preeclampsia. And another is the APLA syndrome, which is well established that we can give aspirin along with heparin, and if we give both, then the success rate preventing losses are more. So these two are areas are well established. Other things maybe we have to really wait, because there are reports of some side effects of aspirin to the baby, as well as long-term side effects to the mothers and morbidity. Thank you very much, madam. It was a very good presentations. We are all, it was very good. Thank you.
Now we will like to invite our next speaker, Dr. Reema Kumar. She is a MSDNB FICOG Senior Advisor at Army Hospital, New Delhi. She has a special interest in invasive fetal therapy and high-risk pregnancy, and has served as consultant at various military hospitals. She is presently posted as Senior Advisor and Fetal Maternal Specialist at Army Hospital. She's a recipient of Chief of Army Staff Commendation and Army Commander's Commendation. She's Executive Member of Society of Fetal Medicine and Co-Chairperson of Subcommittee of Fetal Medicine, AOGD. She has numerous publications in national and international journal. So we invite you, Dr. Reema, for your presentation.
A very good morning to all. At the outset, I would like to thank the AOGD team, Dr. Vatsala, Dr. Aparna, for inviting me over. There's some glitch. They say that you have to start while other. Is my screen visible?
No.
Okay.
Yeah, it's visible now.
Okay. So, am I clearly audible?
Yes.
So a big thank you to the AOGD team, Dr. Vatsala, Dr. Aparna, for having me here. And I thought of taking a very simple topic. We all understand that medicine is always evolving, and we are moving on from consensus to controversies, and good evidence changes everything. It changes consensus to controversies and controversies to consensus. So a very simple topic, which all obstetricians in day-to-day practices, that if we ask for an ultrasound in the 3rd trimester, should it be at 32 or at 36 weeks? We all understand that we are extremely vigilant on a high-risk group. We formulate a plan. We offer them growth scans from 28-week onwards. But what about these low-risk women in our clinical? Is our clinical examination good enough? Or do we need to offer a 3rd trimester ultrasound universally? Now, the question is that why do we need to offer a 3rd trimester ultrasound? Because we need to identify these small for gestational age babies. These are the ones who are prone to tolerance. They have reduced tolerance to hypoxia. They have poor perinatal outcomes. There's cerebral palsy, childhood obesity, metabolic syndrome. And therefore, we need to pick up this hidden group of FGR, which is extremely important in improving our outcomes. We're very worried about this small late FGR. This is a group that is a milder form. It is not immensely sick, but it is poorly impacted by a second hit. And the second hit comes when the labor starts. And this is responsible for the unexplained fetal demise. And in a low-risk population, we all understand that this is just not acceptable. So we also understand that there's evidence to prove that there is poor perinatal outcome, not just in fetuses that are less than 10 centile, but the adverse perinatal outcome starts in fetuses from the 50th centile and starts going up. And if we identify these SGAs, we definitely improve their outcome. And that is the reason that detection becomes extremely important. We also understand that studies have proven that a lot of randomized trials that have been done, we need to induce, the Digitat came, the Trufel came, and none of them established any change in the outcomes of these SGA babies. And the reason was that these babies were identified early. And once you identify them early, you are vigilant on them. And once you're vigilant, you definitely improve the outcome. Which modality to choose? Fundal height, only 20% of detection rate. Fetal movements is 40%, but a universal ultrasound definitely improves the outcome. Nicolaides has come up with a contingent model. They say that in the first and the second trimester, now with the preeclampsia screening, the uterine artery Dopplers, let's pick up all the cases that are high risk, subject them to a third trimester ultrasound. In this way, we reduce the routine third trimester ultrasound by 50%. But is that possible in our country? Are we all following a contingent program to pick up all our high-risk population? Or is it just on history alone? And therefore, we need to know that whether we really need to perform a third trimester ultrasound in a low-risk woman, and if yes, whether it has to be at 32 weeks or at 36 weeks. Now, as far as the recommendation of different professional bodies go, there is consensus on the definition. But as far as screening in the third trimester goes, UK, America, they all say, United States, that we don't need to do a third trimester ultrasound. It's only the French group that says that we need to improve the outcome by doing a scan at 32 weeks. Now, this was a Cochrane review in 2015, which said that a routine late pregnancy ultrasound is not associated with improvement in overall perinatal mortality. And it definitely is not useful in picking up the babies with a birth weight less than the 10th centile. But what brought about a paradigm change was this study, the POP study that came out at Lancet in 2015. It took into account more than 13,000 women, and they said that screening of nulliparous women with universal third trimester fetal biometry tripled the detection rate of SGA infants. So where we started in a selective ultrasound, where for high risk at 20%, by universal screening, we picked up almost 60% of these babies that were expected to be SGAs. And there was another observational study in 2013 that set the ball rolling. It said that if they took more than 2,000 women in the study, and they said that a late third trimester ultrasound was superior in prediction of SGAs. They spoke about a late third trimester. And to take it forward, the Nicolaides group did a study which was there in 2019. I mean, the paper was published in 2019, but its clinical relevance is today. Routine ultrasound at 32 weeks versus at 36 weeks for prediction of small for gestational age neonates. Now, again, they had a problem. They said that we have wide range of charts for fetal size and birth weight. There is controversy of universal versus selective ultrasound on basis of maternal risk factor. Let's do an abdominal palpation. Is it good enough? Or a serial measurements of symphysis fundal height. There was lack of consistent data on the performance of expected fetal birth weight versus abdominal circumference for prediction of SGA neonate. And there was limited data on the best timing for a universal third trimester scan. Somebody would ask it at 32 weeks, somebody would ask at 28 weeks, somebody at 36. So which is the best timing? So the aim of the study was to evaluate and compare the performance of a routine ultrasound expected fetal birth weight and fetal abdominal circumference at 31 to 33 plus 6 weeks and 35 to 36 plus 6 weeks gestation in prediction of a SGA neonate born within 2 weeks or at any stage after assessment. It was a big study, prospective study of more than 21,000 women that were examined at ultrasound at 31 to 33 weeks, more than 45,000 women who underwent routine ultrasound at 35 to 36 plus 6 weeks. The maternal demographic characters and medical history was recorded. And a third trimester by an expert person, an ultrasound examination of the fetal anatomy and measurement of fetal HC, AC, female length, etc. was carried out by Haddock et al. And pregnancies with aneuploidy definitely were ruled out. And the outcome measure was delivery of a neonate with a birth weight less than the 10th or the 3rd centile for the gestational age. Well, the ROCs were used, and we all know that the ROC curves are a trade-off between the sensitivity and the specificity, and the area under the curve tells us the fullness of the test. So this was the receiver operating characteristic curves of estimated fetal weight and the fetal abdominal circumference at 35 to 36 plus 6 weeks for the prediction of small for gestational age neonates at the birth weight less than 10 centile and at the less than 3rd centile. And we were looking at the delivery after 2 weeks or any stage after delivery. And the results showed us that the area under the curve in screening by expected fetal birth weight for a SGA neonate with a birth weight less than the 10th and the 3rd centile within 2 weeks or at any stage after screening at 35 plus 2, 36 plus 6 was significantly higher than the area at 31 or 233 plus 6 weeks. So an ultrasound at 35 to 36 weeks definitely did better as compared to one at 31 to 33 plus 6 weeks. And again, when we took the expected fetal birth weight Z-scores and the abdominal circumference Z-scores, it was found that at 35 weeks to 36 and 31 to 33, the predictive performance of expected fetal birth weight definitely did better than the abdominal circumference. However, it was in the early gestation that the abdominal circumference and the expected fetal birth weight fared equally. So to answer the clinical relevance is that in early gestation, AC and expected fetal birth weight are both good enough, but as pregnancy advances, is the expected fetal birth weight that gains more significance. And again, screening at 35 to 36 weeks predicted 70% of the neonates with a birth weight less than the 10th centile and 84% of those less than 3rd centile. But is this screening performance good enough? And it only suggested that 46 to 65% neonates could be born at any stage after assessment. So they took this forward and they found that if we want to predict more than 85% of SGA neonates with a birth weight less than 10 centile between 35 to 36 weeks, we need to take an expected fetal birth weight of 40 centile instead of the 10 centile that we take. And this predicted 95 to 99% of the neonates with a birth weight less than the 10th and the 3rd centiles. And those born within 2 weeks after assessment, it was 88 to 94%. So we did increase the screening performance of the test when we took a cutoff at 40 percentile, but this is at what cost? This is at the cost of the positive predictive value coming down, an increase in the false positive rate. And when this happens, it extrapolates to iatrogenic delivery and early delivery, even in those fetuses that may be normal. So what does this study tell us? That the predictive performance of a SGA neonate of a routine ultrasound examination during 3rd trimester is higher if the scan is carried out at 35 to 36 than at 31 to 33 weeks. So here, we need to remember that when we order for an ultrasound, it has to be at 36 weeks. The method of screening is expected fetal birth weight than fetal abdominal circumference at this gestation. Outcome measures of birth weight are good if we take it at less than 3rd centile than at 10 centile, and delivery within 2 weeks after assessment is what is important. Now, again, our cutoff needs to be changed to 40 centile if we want to increase our sensitivity of pickup by the 3rd trimester ultrasound. Now, of course, this study was a large population. That was the strength of the study. The limitation of the study was it was not a randomized trial. So what does this study tell us? That the routine third trimester ultrasound constitutes a screening than a diagnostic test. Let's discuss what is important. The weight when we take, we've realized that the area under the curve, we've seen the results that in early SGAs, both parameters, the abdominal circumference and the expected fetal birth weight are important. But in the late SGAs, the expected fetal birth weight is the best tool to identify. And of course, this is substantiated by another study by the Nicolaides group, which says that the Hadlock is still the best model for finding out the expected fetal birth weight. And the head circumference, the AC, and the female length is the most accurate prediction of fetal weight in all the babies. And this was similar to the study which we've just discussed. Now, coming to the second point, the predictive performance of SGA on the routine ultrasound. Yes, 36 weeks is better. Do we have more evidence to support this? This was this root trial. This was ultrasound for fetal growth restriction at 36 to 32 weeks that was performed by the Barcelona group. And they found, they took a huge number of women in their study, and they found that the detection of SGA at 36 weeks was definitely higher to the tune of 61% compared to 32 weeks, which is at 32%. Now, coming to the third point, the predictive performance at 10 centile, we got a modest screening performance by the study. Now, if we take the cutoff at 40 percentile, we get a prediction of more than 85%. But we need to know that 1 in 4 actually will only be SGA at birth. So we have a huge number of false positive, and we need to balance this true and false positive number. So we need future studies to investigate the potential methods for reducing the false positive rate in the group of expected fetal birth weight of less than 40 centile, but not compromising on the pickup of the SGAs. So the question is, and something that we all need to ponder over, is that can fetal growth velocity or the fetal Doppler parameters have a role in this subgroup? Well, this was another study by the Figueres group. They said that there was no added contribution of growth velocities for prediction of SGA or severe SGA when a single third trimester expected fetal birth weight measurement is already performed. So could growth velocity decrease our false positive? We really don't know. And the POP study that I discussed earlier that had come out in Lancet, they did mention that the abdominal circumference growth velocity definitely is a better predictor of adverse outcome amongst the SGAs. Again, we've routinely known that the addition of Dopplers like the CPR and the uterine artery to the armamentarium of a routine third trimester ultrasound definitely will help us in decreasing the false positive rate if the cutoff centiles are increased. And the question is, the most important question is that we do this strategy, do we actually reduce the adverse neonatal outcomes related to the SGA condition? Well, this was this IRIS study, which was the effectiveness of routine third trimester ultrasound to reduce the adverse perinatal outcome in a low risk pregnancy. This was a nationwide multi-centric study where more than 13,000 women were taken, all of them were low risk, and it did find out that when we do a third trimester ultrasound, there's a higher antenatal detection of small for gestational age fetuses, but there is no reduced incidence of severe adverse perinatal outcomes. They talk of severe adverse perinatal outcomes, but friends, in today's era of fetal medicine, we are not just looking at the adverse, severe adverse, we're looking at any adverse perinatal outcome that may affect our baby. ISWAC has come up with its recent guidelines in 2020, where it talks about the growth velocity, the fall in growth. It talks about the Doppler inclusion in the armamentarium, but it does not talk about the role of third trimester ultrasound for detection of SGAs. So the controversy still remains is that should we do a routine third trimester ultrasound in a low risk woman? We still have no definitive consensus. It still remains a controversy and we need more evidence. But the question that is answered is that if all of us will definitely, if our patient can afford, ask for a third trimester ultrasound, even if the evidence still does not support it. So the time that most suits is 36 weeks. And we have enough evidence to tell us that if we order a third trimester ultrasound, it needs to be performed at 36 weeks. My dear friends, good evidence can change all controversies to consensus. In today's era, we need better detection, we need better treatment, and we need better outcomes. And for that, I feel that we can order a third trimester ultrasound, and we best do it at 36 weeks. Thank you.
Thank you very much. Thank you, Dr. Rima. It was an excellent presentation, and I agree, we all agree that the controversy still remains. And you all know that most of the FGR are actually late onset FGR, and these are detected between 30 to 36 weeks. Now, I agree with you. Most of the audience will agree with you that if your infrastructure allows it, and if the patient can afford it, is better to get it done, so that the detection rate will be, may have some role to play. Today, we did not get evidence that whether it will reduce the morbidity of the baby, neonatal morbidity, but still there are certain things which can be preventable, and maybe in near future we'll have the answers. Thank you very much. Thank you very much. If there are any question, then
there is a. Can I make a comment?
Yes, please, madam. Please.
Really nice to listen to you, Reena. We actually did do something similar to see is a third trimester scan useful or not in a government hospital setting, and we realized that even if we told the obstetricians that look, you've got a FGR baby, they did not change their management, and whatever the perinatal outcomes were, it was because of intrapartum stillbirths or intrapartum fetal distress or emergency fetal distress. So we think that even if the fetal medicine people say that, look, this baby could be compromised, it could be a problem, the obstetricians don't act on it in the labor ward. So I don't know what to do about this. I mean, it's not that we don't identify it, but if you look at all your data, Neither even with you, Reena, perhaps not so much in RR, but in the government hospitals, if you are doing your perinatal morbidity, mortality meetings, surely most of them are intrapartum related problems. So what's the point? I mean, I feel what's the point of us telling you this baby is going to have problems and no one bothers listening to us? So what are your comments on that?
I think, ma'am, that it will take time, but as fetal medicine is growing, the NT scan was not spoken about a few years back, and now we talk of screening, combined first trimester screening. Eventually, the uptake with more evidence coming in will be there, and we look, a few years down the line, I'm sure that it would form a part of antenatal care. Maybe it would take some time.
No, but say you do it and you say this is an FGR fetus, and then you have suggested that maybe she should be induced at 37 weeks. The obstetrician does not follow your advice in the government hospital.
I think more of education and more of I mean, that has to keep happening, ma'am, to let them realize that.
I'm glad that Dr. Kiran, Dr. Sangeeta are here.
So can I come in here, Anita?
Comment, yeah, please.
I think we are running little short of it. Ma'am, you can be little brief, maybe 30 seconds.
No, but maybe she comments and.
Okay, I think let me come in here. Good morning to all of you. Since you've talked about the government hospitals, so I think, Anita, I think we need not be so disheartened. The people are listening and they're trying to pick up the FGR. It's not that obstetricians are not listening. There is the induction of labor for this indication has really risen up. It's not
so that's good
only,
to know.
But only thing is that that way you are right. Even if they induce these patients little early, the chances are that in a busy hospital you can still end up having intrapartum stillbirths. That is the only thing that we need to be more vigilant. You know, that kind of vigilance and continuous monitoring of such a fetus in the labor may not be that you can't do it that I mean with that intensity as you can do it in a private setup. But then it's that people are obstetricians are not listening. I think I would disagree on that. The inductions are being done, but yes, I agree on that point that you
Okay,
can
thank
have
you very
more
much. And
intrapartum issues
at
like
the outset, yeah, very true.
Thank you.
And
Thank you.
thank you very much. And at the outset, I thank the organizer, particularly Dr. Aparna, Dr. Vatsala, for giving us this opportunity. And thank you, everybody, all the speakers, excellent, excellent presentations, and the audience. Thank you very much.
Thank you.
Thank you, sir.
Thank you all for such an outstanding session. We now move on to the panel on case-based discussion on fetal growth. I'm glad to invite the two eminent moderators for this session. Dr. Vatsala Dhadwal, ma'am is Professor, Department of Obs and Gynae, AIMS, New Delhi, and Dr. Chanchal Singh, who is lead consultant at Birthright by Rainbow Hospitals, Malviya Nagar, New Delhi. Before this, we have a short video for all of you.
Dear doctor, pregnancy is a beautiful journey in a woman's life. A journey where she needs care and your expert advice. As her body goes through a 9-month-long transformation, she requires extensive nutrition. Nutrition that nurtures her growing baby and helps her navigate through some unpleasant experiences of pregnancy. Introducing Trimacare, 9 months of extraordinary care for an extraordinary role. A prenatal pill designed to fulfill complete nutritional needs of Indian pregnant mothers. Trimacare 1, 2 and 3 are specially designed for each trimester of pregnancy and the growing needs of mother and child at each stage. Trimacare is formulated by experts following the ICMR guidelines. It's made with iron, folate, calcium, vitamin D, omega, and more than 25 nutrients essential for a healthy pregnancy. Trimacare adheres to multi-micronutrient supplementation known to reduce risks of low birth weight, preterm births, and babies born small for gestational age, and also helps in fetal neurodevelopment. With the right ingredients, Trimacare helps reduce commonly experienced symptoms in pregnancy like nausea, vomiting, morning sickness, constipation, UTI, leg cramps, and hypertension. Trimacare is free from allergens, is non-GMO, has higher absorption value, is gentle on the stomach, is 100% vegetarian, and is made with premium ingredients. Dear doctor, now no more trouble of prescribing multiple pills to your pregnant patients. Choose trimester-wise care. Choose the right nutrition for Indian pregnant mothers. Choose Trimacare.
Yes. Hello. Tanchul, have you joined us? Can you hear me?
You're audible.
Okay, so we have quite a difficult topic, which I hope my expert panelists would make it simpler, because diagnosing and managing fetal growth restriction remains still an enigma for most of us. So I have an expert panel with me. So I invite them. Dr. Anita Kaul, she's clinical coordinator, Apollo Care Center for Fetal Medicine. And she's one of the leading experts on fetal medicine. And I think one of the few people who give very clear, crisp, to the point answers. So welcome, Dr. Anita. Dr. Kiran Kuleria is professor, director professor, Department of Obs and Gynae, GTB Hospital. and a very nice person and very close friend. Next. And Dr. Kamal Gujral, she's a head of the department and chairperson, Institute of Obstetrics and Gynecology at Sargangaram Hospital. Welcome, ma'am. And with me, my young budding specialist, Anubhuti. And next, and Dr. Poonam Tara. And she's also a well-trained fetal medicine expert. And she's working in Max Hospital, Saket. Welcome, Dr. Poonam. That's it. That is the panel, and we'll start. So before going to the cases, I thought we would have a little background information about fetal, about the definition and the diagnostic criteria. So it becomes easier to discuss the cases, and it becomes easier for the delegates to understand. So when we talk about fetal growth restriction, the definition is it is defined as a condition where the fetus does not reach its biological growth potential as a consequence of environmental factors. How do we put this definition into clinical practice? How do we measure it? So the most common way of defining a small fetus is by taking an estimated fetal weight on ultrasound as less than 10 centile, which we also say is small for gestational age. So the problem with this definition is they are not uniform across, given by different societies, or a uniform definition is not followed across the country. But most common criteria taken is an estimated weight or an abdominal circumference less than 10 centile. Few countries use Dopplers also in defining fetal growth restriction. So if you look at these old definitions, the problem is we cannot distinguish a fetus who is constitutionally small from a one who is small because of a pathological process, mainly uteroplacental insufficiency. And it also does not diagnose fetuses whose weight may be more than 10 centile, but they are growth restricted because they're not following their growth potential. So let us start by asking Dr. Kiran Guleria, how has the definition of fetal growth restriction changed lately?
Is it me?
Hello.
Is it me or is it Kiran Guleria?
Okay, Kiran Guleria. I know.
Okay. Yeah, who is
sorry.
kgs, no? So,
Okay. Thank you so much. I think, can you hear me?
Yes, yes.
Yeah. So I think thanks for asking that question because, you know, in the last 15 years or maybe last 10 years, whenever I have given a lecture on FGR, I have never been able to use my slide again because the things and the concepts change every time. So it's a kind of evolving definition, and the definition has changed. Now, first thing is that you have to define that this is a small fetus, which you have rightly said that it is the estimated fetal weight or abdominal circumference, which is less than 10 centile. So, but to say that it is FGR, you need to add Doppler studies to it. So that is one addition, that you use the Dopplers, especially the umbilical artery Doppler, and also in later stages, the uterine artery Doppler or cerebroplacental ratio. That the ratios, which can help you in further defining that it is a fetal growth restriction. And third thing which is there is that in patients where when you're following a fetal growth curve, so some of them may be falling in the normal centiles, but when you do the subsequent monitoring of their ultrasonic fetal growth, then you see that they fall off that trajectory. And if that fall is more than 2 quartile or more than 50 centile fall, then also they will come into the definition of fetal growth restriction. So that I would say there are two major changes are the addition of Dopplers and also growth velocity, which can help you in defining the fetal growth restriction. And as you have already projected, that Delphi consensus definition is there, which have clearly defined two phenotypes, which are demarcated by the gestational age of 32 weeks. Less than 32 weeks would be an early FGR, and more than 32 weeks would be, or equal to 32 weeks would be a late FGR. Both are different phenotypes, which are different in many ways in prevalence, in diagnosis, in monitoring, and in deciding about the timing of the delivery. And as per the definition, it is if there is a if the estimated fetal weight or abdominal centile is less than third centile, it is by itself indicative that it is a growth restriction, or if the uterine artery Doppler shows
So
absent.
just to summarize, like they have divided into early and late onset, and the fetuses which are less than 10 centile to differentiate between the small for gestational and actual growth restricted Dopplers are being used, and for late onset FGR the growth velocity, and standalone criteria are severe growth like estimated rate or AC less than third centile, or if the umbilical artery Dopplers have normal like absent or end diastolic flow. So following this, like why do we need to differentiate whether it is actually SG or FGR fetus? Dr. Anubhuti?
So thank you, ma'am. We need to differentiate between the two because the two have a different in utero adaptation, which are reflected in the Doppler changes that we discussed, and they have a different perinatal outcome. The actual FGR fetuses have a poor perinatal outcome due to placental insufficiency, and they have higher chances of stillbirth and problems in labor.
So it's important to label them so we know which ones require more intensive monitoring, and then accordingly we can plan when to deliver them. So Dr. Gujral, why is it important to differentiate between early and late onset FGR? Are they same or they are different?
No, they are different. They are different in the timing of onset, you said. Their difference is the incidence showing on the slide. Besides that, early starts early and it goes to a hierarchy from arterial to venous stages. And it's a natural adaptation to hypoxia. They do have a higher mortality morbidity. Here it is the timing of delivery and monitoring. When do from arterial to venous in less than 32 weeks, once a venous change occurs, I mean doctors, that's the time to act as we subsequently see. Now, late onset FGR, umbilical artery Doppler is abnormal only about 10-20% of the cases. The weight may be just on the normal centile, but the cerebral circulation redistributes itself, and that is important. So MCA and other ratios are being used. And these babies have lower tolerance to hypoxia. They have a lower mortality, but the problem is detection. So before us, Rima so beautifully brought out that one ultrasound at 36 weeks, and I am a very, very strong proponent of one ultrasound at 36 weeks. Believe me, in practice, if you have in a low-risk woman, one stillbirth, where you've not done the ultrasound, the whole family comes back to you, why did you not do an ultrasound? I agree that in 500, 400, I may be picking up one, but I think that is where you'll pick up in late onset FGR, and it's extremely important because they just die like that.
So that's very rightly put.
The problem is diagnosed, and unless you do a third trimester ultrasound, there's no way you can diagnose. 20% sensitivity, like Rima has just shown. How do you know? And movement, and nothing helps you. Everything, it's just one ultrasound at 36 weeks. And I want to tell Anita, we are doing absolutely ultrasound at 36 weeks, even for our free patients. That's all about it.
So thank you, ma'am. So that is well said. Early and late onset have a different pathology, and they show a different response to hypoxia and this changes in the Doppler vessels. Doppler in the different vessels is how we monitor early onset FGR, but changes in the umbilical artery, other vessels do not occur like in early onset FGR in the late onset. So diagnosis and monitoring in late onset is a challenge, as we will see in the next few slides. So there are some Doppler changes occurring which do predict fetal compromise in early and late onset FGR. So Dr. Poonam, can you just briefly tell us how these Doppler changes progress? Because these are going to help us in monitoring the fetuses. So it'll help us in understanding the cases as we discuss later. Dr. Poonam?
I think can you hear me?
Yeah.
Okay. So thank you, Dr. Vatsala. In the early FGRs, there is a cascade of ultrasonic features that we can see, starting with the increase in the umbilical artery Dopplers, after which the MCA sparing, the brain sparing can happen, followed by the absent flows of the umbilical artery, the reversal of the flow. And this can happen simultaneously. So as the absent to the reverse is happening, the ductus venosus can also start showing changes with the increased pulsatility index to becoming absent to reverse, which is where the management will come and the intervention to delivery will come, as we will see further. In the late FGRs, this cascade of features is not followed. So once we have established that this baby is small for gestational age, and after 32 weeks, which is where we make a, that gestational week is where we say before that is early and after is late. If there are changes in the MCA PIs and the umbilical artery Dopplers with the ratio, because there could be very subtle changes between the two, and we could be missing few FGRs which present late. Late FGRs are important, as said, because of the stillbirths that can happen and the neurodevelopmental outcome that is associated with the late FGRs. So if the CPR is less than the 5th centiles, then late FGRs along with the estimated fetal weight and the abdominal circumference less than 10 centiles would lead us to the late FGRs.
Thank you, Dr. Poonam. So we have understood how we define fetal growth restriction. There is an early and late onset FGR. We have seen the pathophysiology is different, and we see the changes that occur in the Doppler in the various vessels is different. In the early onset, it follows a particular sequence which we can use for monitoring. But in late onset, the vessel changes may not occur. So the diagnosis and the monitoring does become a little difficult. So with this background,
one more important thing to highlight here is the biophysical profile. Right. The physical profile is not of much of importance in the late FGRs, because it can lead us to false negative, even if it is high. Even if it's normal, we can still have stillbirths, even if it's done, within a week's time, which is very clear. The evidence is quite there that if the fetal tone is not there, we're talking with the respect of the small fetuses with some changes. So the biophysical profile does not add much to the late FGRs as compared to the early FGRs.
Right. But still, we have to use these tests for monitoring. So once we diagnose a small baby, the management is monitoring and timing of delivery. And especially for the early onset FGR, we have to make a judgment between either the problems of prematurity or intrauterine fetal death. So it's a very delicate balance to handle. So once IUGR is diagnosed, we have to prevent prematurity as well as prevent intrauterine death. And for that, monitoring is very important. So we have an armamentarium of various vessel Dopplers, and then we have biophysical profile, CTG, to be done. And it has been shown that integrated fetal monitoring is good. That is multi-fetal Doppler, multi-vessel Doppler, and fetal heart rate analysis and biophysical profile, which is definitely more relevant to early onset FGR, but we also use the same monitoring for late onset FGR also. So how do we manage FGR, and what is the stage-based management of FGR? Dr. Anita, would you please highlight?
The problem is that how is FGR managed where there are fetal medicine units and where there are no fetal medicine units? So the situation is that if you are rolling out delivery of healthcare, you need to you need to decide when should whatever you're monitoring, because this needs to be done by not high-end specialists, they need to be done by generalists. So when do you sit there and say that, okay, this patient now needs to go to a fetal medicine unit and needs intense monitoring? So the Gratacos or the Barcelona system, which is like a NHS system for the entire country, where they were trying to say that, okay, anyone who's monitoring ultrasound, is monitoring small babies, when should they sit there and now escalate the care to a higher center? So they got this computer-based program whereby you could put in various parameters. I mean, it's still there. So anyone, say, even for us in India, who are not sitting in tertiary level hospitals, but who are sitting, say, in peripheral clinics, this is a very good thing for them to use, where you put in the AC, you put in the scan, and then that software tells you, are you stage 1, stage 2, stage 3, and when should you be sitting there shifting into a tertiary cancer center, and when should you be doing that? So according to me, this management protocol, according to severity, is really just to standardize care. So for instance, with us, in a tertiary care hospital where you have that patient admitted with you, where you can sit there and, do daily scans or everything, or you at AIMS, Vatsala, where you can do it more intensely. It is not necessary, you can sit there and play around a little bit. So even if, say, for instance, if there is an absent reverse end diastolic flow in the umbilical, but the ductus is still fine, stage 3 may say that, okay, maybe 30 weeks is a good time to deliver this patient. But if she's under a fetal medicine unit and where you are monitoring her more intensely based on the DV, you can push it for a week more, maybe push it for 10 days more. So for us, what I believe is that we also need to do something similar in India. We also need to sit there and decide that the generalists who sit there and do the scans need to know when should they escalate the pregnancy, and they are monitored by the fetal medicine people. And I think this protocol is good for that. So as you can see from the slide that you've shown, is that you're doing the AC, you're doing the umbilicals, and basically it is that, okay, if you have a good umbilical, take her, even if there is a raised PI, take her and deliver at 37 weeks. If it is absent, take her up to 34 weeks. If it's reversed, deliver her by 30 weeks, and, sort of a more standardized practical management. To be honest, we don't use it. I don't know amongst the panelists who use it. Do you use
We
it?
use the state.
You use it?
Yeah, absolutely. Absolutely. Daily ultrasounds and daily.
That I would think that no, but well, we don't. Chanchal, do you use it? I don't know if Chanchal uses this, because the fetal medicine people to some extent wouldn't use it, because we say that we can assess the baby and we don't need, so if I have a baby which is reverse end diastolic flow, which is really active, it's moving, there's so much amniotic fluid around the baby, the mom's blood pressures are normal, her ductus is good, I'm not going to sit there and deliver at 30 weeks. I'm going to say that let me try and push it a bit more, because I'd rather have this baby inside. But
that's true. What I meant that
I agree. Say in the secondary level hospitals where they aren't so much used, say for instance, like the municipal hospitals where they then refer on to LNJP and GTP and all these places. These are the people who should be using it, because they need to know when to refer on.
Actually,
I agree.
Some kind of a guidance on which you can make your management. And once you have a fetal with early fetal growth restriction, definitely there is intensive monitoring. So referral to a tertiary care center or where a maternal fetal medicine expert is available is good. We always individualize management. So it is like, it depends on case to case. So these are basically guidelines saying that you have to basically balance between the risk of death and delivering premature. So if it is an absent flow, you can pull up to 34 weeks, everything is fine. But if even if there is like sort of absent flow and she's 32 weeks, but if it's showing decelerations or if the maternal condition worsens, because most of the mothers who have severe FGR early onset would have preeclampsia. So you have to take a call to deliver. So you have to see everything in toto, but this gives
But
a
that's
good.
what I'm saying. I think that these patients should be seen, say, at AIMS. I don't see that someone who's working in a secondary level hospital should be taking these decisions.
No, they have to be referred.
It should be the way we have it in other European countries, that these are screening tests, and as soon as the woman reaches stage 1, then she should be referred on to a hospital where they're used to doing this. I think it's unreasonable to expect, I don't know, maybe think of, say the ESI hospitals perhaps, or any of these other hospitals.
So basically it gives a message that, I mean, everyone, most of us would be handling such cases, but we should know when to refer and where to refer. And then definitely it gives you a cutoff, like if you have a fetus who is at 28 weeks, has an absent flow, you're not going to deliver, you can monitor till reversal, or if there is any abnormality in the DV. So very preterm babies, we know like how long can we pull by using additional vessel Dopplers and using like maybe CTG. If you have, you can use computerized CTG. So it just gives you a guidance as to how long you can pull in a premature baby. If it is 34 weeks with the absent flow or reverse flow, then if my nursery is good, I'm going to deliver. I will not wait. So it just is a guidance for managing, and I think for us it works reasonably well.
No, but the thing
Dr. Vatsala, we in Ram get a lot of references with absent flows coming via casualties. So I would say normal obstetricians across NCR are aware that absent flow at least has to be referred, if not earlier.
Right.
Little oligo, 7 they would define as oligo. We always get a reference. We may not react to it.
So
So
I
there
think
is a little
forward and
awareness
discuss
of
the cases
across.
and how
Yeah.
we are utilizing these in
Yeah,
managing cases.
every casualty we get, middle of the night, absent flows, at least they're scared at that.
I feel the message that should go out is
Yeah,
say,
definitely early, that's true.
forget us, the radiologists who are monitoring these people, they need to know that this is, now she's getting into a tricky stage. She should be referred to a fetal medicine unit and further monitored.
If we can
The earlier you get, better you have to deal with it. I would say that, but
so let's proceed to the cases and let's see how we are utilizing this all this knowledge that we have gained till now in managing the cases. So Dr. Chanchal, would you please start with the first case?
Good afternoon, everyone. So nice to.
Whose phone was that?
So sorry. So all.
Hello.
Yeah.
Chanchal, can you proceed, please? Because we will run short of time otherwise.
Hello, can you hear me?
Yeah.
Yeah. So good afternoon, everyone. I'm unable to see the screen.
We can see the screen.
Yeah. So, Anubhuti, so the first question, the case one is directed for you. So you often get referrals like these, that the suspected fetal growth restriction because the head parameter, there is a lag of 3 to 4 weeks between the head circumference and the abdominal circumference. So when you get a report like this, what is your interpretation? How would you like to proceed with this? Is this growth restricted? She's been referred to you because of growth restriction.
Ma'am, I think this report is complete. It's totally incomplete, and we do not talk about the growth in terms of weeks. We talk about plotting them on the growth charts and the centiles for each of those parameters. And apart from that, there is no mention of the Dopplers and the AFI with this report. So this report needs to be completed in all sense.
So what information would you like next? What information would you need?
So I would like to know the centiles for the abdominal circumference. I would like to know the centile for the estimated fetal weight, the umbilical artery Doppler, the MCA Doppler, and the AFI.
Right. So as you can see that both the head circumference as well as the AC, they are within the normal range. You can see the centiles there when you plot it on the chart. So although there may be a slight discrepancy, but overall the fetal weight is within the normal range. And you saw that the Dopplers are normal and the AFI is normal. So what would be your interpretation here?
So mostly it's a SGA baby because the Dopplers are normal. So I would like to follow up this after 2 weeks with a growth scan.
Right. So it is very important. How do you think growth charts are useful? What is the role of growth charts?
We will plot the trajectory of growth of this fetus on the growth chart to see if it is following its normal curve of trajectory. Is it actually small after 2 weeks? And the interval growth can also be visualized on the growth chart.
Right. So, I mean, it doesn't matter which chart you use, so long as you use a chart, because not only does it give you a definition of what is small, it also tells you how small is small. And as everybody, all of my previous panelists highlighted, that it is the visual representation of fetal growth over a period of time. So the concept of interval growth has become very important rather than an absolute snapshot at one point in time. Let's go on to the second case. So in this case, you have got sorry, I can't see the screen.
Can you?
I can't see the screen.
So should I read it out for you?
Yes, ma'am. Please go ahead. Please.
So primary gravida, 37 weeks and 4 days of pregnancy. She got a growth scan done and the estimated fetal weight came at 8th centile. Umbilical artery Doppler was normal and she had a first trimester screening and anomaly scan which were normal. So what is the further management?
As the fetal weight is less than the 8th centile, and although the umbilical artery Doppler is normal, but we have discussed that in late onset IUGRs, it's the MCA Doppler and CPR which is more important. So I would need more information about the Dopplers of the MC and the CPR.
So I can see the screen now.
Okay.
So what would you like to do, Anubhuti? How do we?
Like to measure her MCA Doppler, check her MCA PI, and calculate the CPR, and also look at the AFI.
Right. So it is very important to distinguish these constitutionally small babies from late onset fetal growth restriction, and that is the information that you need here, the MCA PI and the cerebroplacental ratio. So next slide, please. So both of which were normal for this lady. And because this was normal, when would you like to? So you can see that the estimated fetal weight is on the lower line of the graph, which is about 5.5 centile here, 2240 grams. When would you like to see her next? However, the MCA PI is normal. Next.
If the MCA PI is normal, then I can see her after, and the AFI is normal, patient is perceiving fetal movements, if everything else is normal, uterine artery PI is normal, then I can see her after a week and again see about her Dopplers and her biophysical profile. Because in this case, umbilical artery will not be used as a standalone criteria to follow her up. It will be the MCA PI and CPR which will help us in deciding further management.
Absolutely. So although the baby was slightly small, but the MCPI as well as the CPI were normal, the baby was very active. So we did call her back after a week for an NST, and the Dopplers were repeated after 2 weeks when she still had the same clinical picture. So she went into spontaneous labor at 39 weeks and 5 days and delivered a baby boy weighing 2.5 kg with an ABGAR of 9. So this was a case of constitutionally small baby and not a growth restricted baby.
Yes.
So what is the consensus on management of small for gestational age? I mean, this is a common thing that we encounter because we do see a lot of babies who are small, but their Dopplers and amniotic fluid is normal. So how do you monitor them?
Absolutely true. And the first step in actually identifying a fetus which is small is whether the fetus is SG or FGR. And although we say that the FGR fetuses are at more high risk of intrapartum compromise and more chances of stillbirths, but even an SGA baby needs to be followed up and needs a little bit of monitoring, because there may be some subgroup of fetuses which are at high risk, like especially fetuses with increased uterine artery PIs. So they also need to be followed weekly for fetal growth and 2 weekly for fetal growth and weekly for their Dopplers, and should be delivered between 38 and definitely not beyond 39 weeks to prevent unexpected stillbirths, because we might be missing some abnormalities which are not even picked up by scan. And they also need continuous fetal heart rate monitoring in labor.
So the whole point of using Dopplers in a baby whose growth is below the 10th centile is to identify the subgroup which will be at risk of more adverse pregnancy outcomes. Yeah. Let's carry on. Let's go on to the next case.
Okay. So for the next case, I would ask Dr. Kiran Guleria to discuss with me. She is a 32 years old primary gravida, presenting at 35 weeks and 5 days of pregnancy, no other obstetric comorbidity, and the estimated fetal weight is on the 5th centile. The umbilical artery Doppler is normal. The middle cerebral artery is at 20th centile. So is it enough, or would you like some more information from these Dopplers?
So I think since we can see that she is 35 weeks and she's, as per her estimated fetal weight, it's a small fetus. So I think just knowing the umbilical artery may not be enough. As we've already discussed, for late FGR cases, we need to look at more Doppler. We need to look at her cerebral vascular redistribution, MCA. And also maybe I would also like to look at her uterine artery Doppler. So just to categorize her, whether she is a small for gestational age or are we looking at late FGR? And I think other than that, I also would like to have information on whole of her ultrasound, her amount of LICA, and if possible, depending upon her Doppler changes, if they are there, then also, as you said, we can have a composite with the NST and biophysical also.
So right. So even in a if late onset FCR, the umbilical artery and the middle cerebral artery may be normal, but then CPR may be abnormal. So CPR is more sensitive for picking up hypoxia and also for predicting perinatal outcome. So here, although the umbilical artery and MCR are normal, the CPR is less than 5th centile. Also, umbilical artery PI is more than 95th centile. So the impression is a late onset FGR. So she's 35 weeks in 4 days. How will you monitor her now?
So I think she is also now a late FGR with Doppler changes.
Right.
And in late FGR cases, I think there is no point in prolonging the pregnancy where the Doppler changes have already started to occur. And we need to be very, very vigilant while monitoring them. And only thing which we can do is that we can increase our frequency of monitoring, also starting with BPS and NST, combined with doing her Dopplers at least every weekly, and not to carry her beyond 37 weeks, I would say.
Right. So for the late, yes.
Yeah. So and in between, if I find there is further deterioration or further fall in centiles, then probably take an early decision for terminating the pregnancy.
Right. So what is important about late onset FGR is that fetal deterioration and fetal death can occur rapidly. So monitoring her, since this fetus is showing brain sparing, so we could do her MCPI and CPR, but that is already abnormal. So we are not actually, there is no sort of consensus or guideline as to whether you're going to make a decision for delivery on the basis of these parameters, but it is definitely calls for more careful monitoring. And again, like Dr. Poonam said, biophysical profile, doing a weekly biophysical profile may not be adequate. So it is more intensive monitoring here. So we would like to do her biophysical profile twice a week. And if everything is normal, we would like to deliver her between 37 and 38 weeks and not go beyond that.
Right.
And anytime if there is other signs showing fetal compromise, like Dr. Kiran has already said, we may make a decision to deliver even before 37 weeks. So this patient is reached 37 weeks and 3 days today. So how do we plan her delivery? Induction or cesarean section?
So I think if she has a normal Leica and these are the Doppler changes, and if there is no contraindication to doing a vaginal delivery, we can give her a deliver her vaginally. But then, we have to counsel her, because the late FGR, they are more prone to having, the fetal hypoxic changes. So they can show we really need a very close intrapartum fetal surveillance, continuous CTG monitoring, because they can have more of hypoxic changes, acidemia, so fetal heart changes, non-reassuring fetal heart status, more chances of having an operative delivery cesarean section because of this reason. So the patient has to be counseled on that account, and the delivery has to take place in a center which has all the facilities to deal with these kind of hypoxic fetuses, and also inform your neonatologist that you are going to deliver such a baby. So that kind of counseling has to be there.
Definitely.
And that those kind of preparations have to be there for the labor and for the care of the neonate.
So that is very well said. I think I've covered everything. And the Digitat trial also shows that in cases with FGR, although the study did not show any difference in the conservatively managed or induced group in terms of neonatal outcome or operative delivery, but this opined that it is wise to choose induction to reduce perinatal morbidity and mortality, although their group, they did not take Doppler into account. So yes, now there is a role of Doppler in late FGR, and that is looking at the CPR and brain sparing. And this Dr. Kiran has already discussed very nicely. So for next case, I'll ask Dr. Chanchal to discuss this. Dr. Chanchal?
So, case 4, this lady is Dr. Kiran Gujral. So a 40-year-old primary gravida. She had conceived by IVF, and this was by a donated ovum. Singleton pregnancy, referred to us at 30 weeks, and estimated fetal weight on the 7th centile. And you can see the Dopplers here. So the umbilical artery PI is above the 95th centile, And the ductus venosus you can see looks good. So what would you, how would you proceed with this patient?
She's already an early onset FGR, 30 weeks gestation, compromised Doppler. So she's in stage 1. So I would weekly monitor her, counsel her about the movements, and weekly do my Dopplers, uterine, umbilical, ductus also, and counsel her for the fetal movements, and carry on at the moment. Because she's only 30 weeks, and as long as she goes on okay, she's in stage 1, I'll go on, and I'll wait until absent and diastolic.
Absolutely. Absolutely. So you can see that the umbilical artery PI was high and the uterine artery PI is also above the 95th percentile. So definitely an early onset fetal growth restriction. She was reviewed she was called after a week, but because she started having a few readings of BP about 130/90, she came back in. She came in earlier. This is the umbilical artery after 5 days.
So this is absent already. So get her in steroids, and hold on to monitoring, twice a week monitoring to go on. And I'll hold on till, absent till 33, 34, reverse till 30, 32, depending on the circumstances.
So on the right-hand side, the Doppler, so it is the DV Doppler which will be the decision maker at below 34 weeks.
Yeah.
That's what we mean to say. Next slide, please. So a close fetal surveillance, as Dr. Gujral has outlined, that a close fetal surveillance protocol was followed. The patient was instructed to report fetal cake count, a daily CTG, and at least alternate day Dopplers. At least sometimes the patients may not be able to afford coming in that regularly, but at least alternate day Dopplers.
The hypertension matters, I'll get her in. If she has a reading of BP, she may just shoot. This one should be hospitalized.
This one should be hospitalized because the maternal surveillance becomes important. And you can see that this is now the Dopplers at 32 weeks. These are the Dopplers at 32 weeks.
They're already getting into the reverse flow,
So intermittent, absent, reverse. But look at the ductus. The ductus is still
on.
The ductus is still looking
a little more. I like it to go to 33. So what we found in our thing, something drastically changes at 33 weeks. And in our setup, we've done our data very, very clearly with all the reverse flows and ductus changes. There's no much difference in the perinatal mortality morbidity between 33 and 34. The literature does say at 32 weeks they become equal, but I think something happens at 33 weeks. So we are carrying them till 33 weeks if possible.
What happened to this one's blood pressure, Chanchal?
Yeah, I mean, unless the BP, maternal indication is separate, I'm talking only of the fetal indication.
So as it goes hand in hand, ma'am. So the patient developing high blood pressure.
When to intervene in blood pressure, when she goes in a severe preeclampsia type liver. So then between 32 and 33. But I just said her gestation at 33 is almost equivalent to 34. Another observation which our neonatologists are particular about, that this one has a very short conversion from absent to reverse, that absent and diastolic for longer than 2.5, 3 weeks gets more necrotizing enterocolitis. So when we do a neonatal counseling, let's say I have an AEDV normotensive hospitalized at 30, the neonatologists are sensitive at that. They don't go beyond 3 weeks, This categorically we observe that NEC is higher because the gut flow is reduced. We know that because of the brain sparing effect. So we have to take a very, very balanced decision, looking at our NICU, looking at the joint counseling we do, whether we intervene at 33, 33 and a half, 32 and a half, depending upon the circumstances.
So in this particular case, although the ductus was excellent, as you can see from the image, the mother's blood pressure shot up and she had 3+ proteinuria. So a decision was taken to give the steroids and
Chanchal, what was the cord gases, the cord pH?
The baby had an number of 7-8 and the cord pH was normal. I have not put it here, but it was normal.
Cord pH usually gets abnormal when the ductus goes haywire at the reverse flow. At this stage, we have also done cord pH. It's mandatory for us to do the cord pH at birth for all FGRs. We never found abnormal cord pH at RADF or at AEDV, So that's what.
Given the high risk of intrauterine fetal demise with absent and reverse, I think we're just reiterating the fact that why do we sit on them? Why do we do daily Dopplers and why do we prolong gestation?
Well, I think you have the truffle trial to answer that the babies without neurological handicap did best when it was a reverse ductal in less than 32 weeks gestation. That was a study of 503 pregnancies where they took 3 groups 1:1:1 randomization, early ductus, late ductus, and CCTG. And we unfortunately don't have CCTG. So here we falter, go more on the ductus and the other Doppler flows. And they had a safety net criteria that if the CCTG is abnormal and 3.5 STV variation less than 32, less than 28, 29 weeks, or 4 in the other group, they will intervene. So we don't have that safety net criteria. Conventional CTG perhaps is not informative in less than 32. This is the problem.
And probably the graph that
relying on the Dopplers and the ductus, Otherwise, in the truffle trial, they said that neonatal outcomes was best 81, 93, and 95% survival. Yeah, unmute.
No, ma'am. Can we keep moving the slides? I can't move the slides.
I can't move your slide. So you've shown that in the slide. 81, right. 93, 95% neurological handicap-free survival. In the late ductus, it was the highest survival, 95%, 91% early ductus, and 80-something% in the CCTG group. So right. This is what you have shown. So practically with us, we are looking at the ductus, and early ductus, if my gestational and my neonatologists are comfortable, I rather act at early than late, because I don't have a safety net, it's just a auscultation, which is not possible, or a, or a normal CTG. That's not informative. And I think if all of us have read How to Interpret Truffle Trial in the ISOC journal, it categorically says only CCTG views. I don't know which one of you have the computerized CTG in your institution. Please, we don't have. Yeah, so this is what we, and the secondary analysis of truffle said that there were 7 deaths, 3 in the early and 4 in the late ductus, and they analyzed this duct, and only 1 had abnormal CCTG. So it's very difficult to say where you act. And they said later gestational age, higher birth weight, and lower umbilicocerebral ratio. They reverse it the other way around, and that is what had better outcomes. So I think you have to take a composite view how to deal and when to deal, looking at your nursery and looking at your own survival charts over the years. This is what. But solely MCA Doppler in early onset FGR, absolutely a big no-no. We have to look at ductus. The message should be less than 32-week ductus. After 32 weeks, open up your MCA.
So can we go back, please? Can we go back to the previous slide? Yeah. So especially the graph. So we especially put this slide because this patient whom we managed to carry on till 32 weeks, this was the CPR right from the time that she came to us first. So you can imagine how low below the CPR is. And one often gets referrals for delivering babies at 32 weeks because 32 weeks.
That's absolutely right.
So that's a very important.
Yeah, true. We had references at 32 weeks CPR less than 5th, prepared for delivery. So Gangaram Niku is better come over. So we carried on till 38 weeks.
Yes.
So it's too much, overuse of technology also is coming into the picture, reference for that. But then you have to take a decision as per the lead.
So to summarize the management of an early onset fetal growth restriction, Dr. Gujral has already outlined that the timing of delivery before 32-34 weeks would be dependent on the ductus venosus. Any maternal indication would of course trigger delivery. There are no agreed upon consensus on how frequently one should monitor, but it is also dictated by the maternal condition. So one would do at least a bi-weekly or an alternate day Doppler, even daily Dopplers for women who are developing hypertension. Usually the truffle trial also showed that if the mother had hypertension, they were able to gain about 5 to 7 days, not more than that. So the maternal disease also had a role to play in deciding how much time one would get. Of course, the timing of delivery is a very important determinant. If my nursery is not comfortable for a 32-week, with a 32-weeker, I may prolong it.
Now, the way would be, Chanchal, with all these reverse and absence and ductus changes, early morning, first thing, do your Dopplers.
Absolutely.
I find the thing is deteriorating. I need time for my magnesium sulfate, but steroids have already given, all right. So I need a couple of hours for my magnesium sulfate neuroproplex.
They all come empty stomach first thing in the morning, and then we decide whether it has delivery condition.
Put in a word. We're good for doing a longitudinal follow-up, but we also need to do biophysical profile and CTG on them because immediate problems immediate indication for delivery would be an abnormal biophysical profile, spontaneous decelerations, or abnormal computerized CTG short-term variability.
In the absence of computerized CTG, if I have a persistent, repeated deceleration,
it is
that's
important.
probably
Otherwise, there's nothing.
So, the singleton pregnancy has caused so much of discussion. Let's see how we can manage the twins. I think twins are even more of a problem.
No, just to finish
They have both issues.
when would you time your steroids? Because that's the other thing we have, that we think that steroids are given to
I particularly, after all the steroids of antenatal corticosteroids, we have switched on to DEXA because we don't have the beta, the celestone in India, we don't make. This is one change we've done. Earlier on, imagine we gave the beta-methasone, which didn't have the required acetate phosphate concentration. And I don't know how our babies lived. So now for a couple of years, we've done with DEXA, typically 12 hourly, 4 doses. Now, we are aware of the fact that after 34 weeks, there is a lot of ill effects on the baby in terms of hypoglycemia, brain development. So we have switched on only till 34 weeks. And as I said, with you guys doing the monitoring for us, we got a window. We got a window of 48 hours, An odd fetus which dies without that 48 hours, I mean, that's bad luck. But let's say you're giving me a reverse flow. I have not given steroid. Gestation age is less than 34 weeks. I have 48 hours. I can do an evening monitoring once again. So it's a lot of dependence on the fetal medicine person. If you carry on, and of course, a burden on your shoulders that if one odd stillbirth occurs, why did you not give a steroid earlier? But we have to know the efficacy finishes after. So what is the idea? To give it at 28 weeks and deliver at 33 weeks, it's useless. And rescue steroids, absolutely, big no should be there at this point of time for this idea.
Yeah. I agree with Dr. Gujral. We also do that DEXA in less than 34 weeks.
So
and then we are contemplating delivery.
Yeah, and when you know that delivery is going to occur in the next 3 to 4 days, that's the best window you know.
Absolutely.
Okay, let's move forward to the next 2 cases, which are basically management of growth problems in twins. So this is a primary gravida, 24 years old, quintuplet pregnancy reduced to twins, a dichorionic diamniotic twin with gestational hypertension and ICP at 30 weeks of gestation. So Dr. Poonam, this is the growth for the 2 babies. So the first baby, the estimated weight is around 10 centile and the AC is less than 2.3 centile. For the other baby, the estimated weight is less than 10 centile. Again, the AC is below 2.5 centile. And when we look at the comparative thing, there is the difference of 29% in the weight of the 2 babies. So, and the Doppler of the smaller one is showing raised PI in the umbilical artery, and CPR is less than 1. And this is 30 weeks. So what is your impression and how do we monitor this pregnancy?
Right. So the Delphi consensus has come up with the twins as well, where you classify the twins with respect to the estimated fetal weight, one entity as less than third centiles. Here it is less than 10 centiles. So it follows into the second option, which is the 10 centiles, along with the umbilical artery Dopplers, which is higher in more than 95th centile in the smaller twins, and the discrepancy between the weight of more than 25%. So this is definitely an FGR in one twin. How do we follow with the MCA PIs of 30 weeks would be I think the consensus is yet not there, but it's probably followed to the same extent as a single gestation, where you follow the umbilical artery and the ductus venosus because it's 30 weeks. And here we have an additional responsibility of a baby whose Dopplers are okay. So we need to continue forward and do the further growth scan in about a week's time.
So
I mean, the growth scan would happen in 2 weeks, but the Dopplers happen in a week's time.
So the monitoring remains the same as in singleton, and definitely the management with one twin is going to affect the other. If you're contemplating delivering, because on the basis of the monitoring of or deterioration in one twin is going to affect the other twin also in terms of prematurity. So in twins,
Right.
you have like SFGR, like Dr. Poonam said, but you may have twins which are discordant also for growth. So even discordancy increases the perinatal morbidity and mortality. And even in discordant pair, both may be either small, like in this, they are discordant and both are small, or they could be, one could be small, one could be appropriately grown. So unlike singleton, you may have a combination of different normalities in the growth. So on following this, we find at 35 weeks, so twin one has estimated weight, which is less than 10 centile. AC is again less than 2.5 centile. For the other one, also the weight is less than 10 centile and the AC is less than 2.5 centile. And when we look at the comparative thing, one is weighing 1.7 kg, one is 1.3 kg, and there's a discordancy of 20%. Now, how do we manage now? She's 35 weeks today.
Right. So what are the Dopplers is what I like to know.
The Dopplers are like the smaller one is showing brain sparing, but there is flow in the umbilical artery. And the other one also has raised umbilical artery PI, but there is no brain sparing.
Well, the twins will do well after 34 weeks. But if we are in a fetal medicine unit and you can have the surveillance more often, I'd probably wait for a couple of days more.
Right.
Because still the umbilical artery PIs are high, but they have yet not reached a level where the delivery is warranted. So give steroids and probably have another scan in 2 days' time with the Dopplers.
So we monitor, and maybe we could pull on till 35 to 36 weeks. But
yes,
here,
as much as we can, if we can do it at 35, 36 weeks, as long as the patient, maternal also, we have to monitor because this lady has gestational hypertension and ICP. So we are paralleling the monitoring as well. So as long as things are stable on that end, we can monitor the baby by the doctors.
so management is not only fetal, we have to also look at the maternal side, which may also warrant a preterm delivery. So she had a preterm cesarean at 35 weeks because of high uncontrolled blood pressure, and the baby weights were 1847 and 1039 grams, so almost a 40% discordancy. So another question, like if this pregnancy had come, there was another patient like this IVF pregnancy at 26 weeks, dichorionic diamniotic with chronic hypertension with GDM, with absent end diastolic flow in umbilical artery of one twin. So Dr. Poonam, would the counseling and management differ here?
Yes, it would differ because one baby, if the one baby is doing well, and the other one with the absent end diastolic flows may not do well in the near future, we have to counsel with one pregnancy at least going till term. But here the other part is that there is a chronic hypertension. So it is very likely that both pregnancies may be affected at some point because of uteroplacental insufficiency. So
suppose 27 weeks,
so the options,
smaller one has reverse flow, poor manning, but the other twin is going well, and like the biophysical profile is good, is doing well. So what do you do? One, is like heading for an imminent IUD.
So the option
controlled. I mean, there was no superimposed preeclampsia or anything.
No,
yes,
the blood fine. The blood is okay. Hello.
So the problem here is that the pathophysiology.
So one is heading for an IUD and the other one is healthy. It is 27 pregnancy dichorionic twin. So option could be given for continuing the pregnancy
So,
if one lands up with an IUD because it's dichorionic.
Yes, they could. It could be, yes, as has to be given of the both to continue or to deliver, giving the pros and cons of each. Now, at 26 weeks, the prognosis is not very good, both the morbidity and the neonatal outcome. So we would give the option of expecting management, knowing that one twin may not go further.
Because it is a dichorionic pregnancy, it's unlikely it will affect the other one. So she could at least carry one baby longer and have a viable pregnancy. So coming to another situation.
Having said that,
I would also say the same, Masla. I think that one would try and predict what are the chances that she'll land up with superimposed preeclampsia. What are the birth weights? What is your nursery requirement? Because a lot of parents still want to go home with two babies. They're not, as much as you tell them that.
Right, you can counsel them, but the option here compared to a monochorionic twin is still continuing a conservative management, even if one twin dies in utero. Definitely, counseling is important.
There's
And
a higher risk
yeah,
of that.
Ratsa, also the co-twin demise, even in the dichorionic twins, the earlier data was 2%. It's slightly gone up with the newer systematic review. So this has to be shared with the patient, especially if it is less than 28 weeks.
right. So
If
let's
the
move on.
IUD has happened less than 28 weeks.
What happened in that case? Your last case, Vatsala?
The last one, I think she had opted for continuing pregnancy despite iodine 1 twin. So coming to the last case, it is a monochorionic diamniotic pregnancy at 23 weeks. So this is for Dr. Anita. Hello.
Yeah, so I can see it.
So this is the growth chart for the twins. So the first one is the weight is around 65th centile, growing well. The other one, it is 21st centile, the estimated weight. And we find there's already a 33% discordancy. So twin A, which is growing normally, has normal Dopplers. Twin B is showing persistently reverse flow in the umbilical artery. And this is the DV flow, which is also showing increased PI. So what is your impression? And can you discuss this case, please?
Essentially, monochorionic twins, everything is worse than with dichorionic. The risk of selective FGR is much worse. The chances of mortality is much worse. So now in this case, as with any monochorionic twins, our job would be to see what is the chance that the small twin dies before we can salvage the bigger twin. So going back to that previous slides, what was the birth weight of the big one? Just out of interest.
This one, 657, 23 weeks.
400 odd grams.
671, 23 weeks.
Okay. So then if one looks at one's nursery and you think that, okay, at AIMS, maybe you want to take her at least till 28 weeks, no? Because your options are, do you manage conservatively? Because in monochorionic twins, sometimes they can just go on and on and on. Their Doppler abnormality to delivery interval can be prolonged versus but that means practically that she needs to have every second day, every third day Dopplers. And is this a practical thing to do with this sort of Damocles sword hanging on your head that any minute one of the babies could, the bad baby could die? Or do you sit there and proactively suggest that you would selectively reduce the smaller twin and hope, whenever you reduce a smaller twin, you always tell the parents that there is a risk of co-twin demise. That means there is a risk that this healthy baby can also die. And if you're willing for that risk, then you can offer it. So I really think that it kind of depends on the parents, but I think if it is at 22 weeks, they're not very keen to monitor. They don't want to live with this fear that any minute you could have an IUD in the smaller one. Then a lot of them say that we proactively want to just reduce the unhealthy twin and take a chance.
Right. So what is also important to understand is selective fetal growth restriction can set in monochorionic twins at a very early gestation. You may even diagnose as early as 18 to 20 weeks. And then again, for classification, we are using the umbilical artery Doppler, and the type 1 with the normal and diastolic flow in the umbilical artery usually has a good prognosis. The type 2 and 3 with abnormal Dopplers would have a worse prognosis. So there may be an option of selective reduction of the smaller twin, as Dr. Anita has said. So I think with that, we would like to conclude. So any sort of, I think, any comments from the panelists, any take-home messages, then we can wind up.
I think the take-home message one would be that, yes, if you want to prevent stillbirths, identify your late FGRs. And once you've identified them, work closely with the obstetrician to make sure, for instance, if there are bad Dopplers and they need induction at 37 weeks, then please induce them.
Don't sit there and send them home and tell them that come when labor pains start. Um, and follow the protocols, because now it's very clear. Time for me, steroids. I do believe that obstetricians give steroids much too early and not appropriately. So I do think that they should be guided again by the fetal medicine people, as Dr. Gujral said, and and give steroids judiciously and at the correct time. And that's all. So that's from me. The others?
Well, the treatment part, I think we are giving a basket of tablets to the patient with no help for early onset FGRs, your L-arginine and lycopene and vitamin C and D and whatnot, and nothing helps, That is what we get a prescription, all line, this line, that line. I think that's a bit too much, and bed rest. Don't move from the bed, you improve the growth. I think these are the things we have to get away with them, with all the
Certain bits that we have to do away.
therapy doesn't work. And one more thing, across NCR, since our hospital gets a lot of reference, I am, shocked that the way they are writing Sladnafil. Well, it is something unheard of. They're not aware of the side effect, 25 milligram TDS in FGRs, and they're living on it.
I told Chanchal to remove that slide. She had one slide. I said, I don't want anyone looking at this name.
Everybody has to aware that now the babies have done bed. Netherlands has withdrawn from the trial. I mean, it's horrible. The smaller the setup is, more is the Slidenafil prescription. Chalo, vitamins, okay, they go off the,
Sildenafil, that's the other.
This is something we should be very careful at giving a message that Slidenafil should not be.
Chanchal, do you want to say something? I spoke a lot, so would you like to just summarize?
No, I think we've covered all the relevant points.
Yeah, you all did a very good job. Thank you very much.
It was a pleasure listening to everyone. Lovely to participate.
Thank you.
Let me have to thank all the panelists for putting in such words of wisdom and making the cases so crystal clear. I'm sure everyone must have benefited. And definitely one has to timely refer these cases to the fetal medicine centers so they can be managed properly. Thank you, everyone. Thank you for joining in for this panel.
Thank you. Thank you, Faith. Thank you very much. For a very
program. I enjoyed
nice
the
panel.
lectures, The previous two lectures were wonderful,
Nice seeing everyone after such a long time. Even
Yeah.
though it is only the pictures.
Yeah.
Thank you very much.
All right.
Thank you.
Thank you so much. I think all the points were very well highlighted. Yeah. Thank you.
Lockdown, unlike the rest of us.
Thank you, Chantal, for helping me prepare the panel. Okay, I think.
Thank you all the esteemed panelists and the wonderful moderators for the session. It was indeed a brilliant panel. I'll move on to the next session of the workshop, the much awaited quiz on the approach to common congenital anomalies. And I'm glad to invite the moderators for the session. Dr. Aparna Sharma, ma'am is the additional professor, Department of Obstetrics and Gynecology, AIIMS.
Before that, we have a short presentation about trimesters. So now we move on to the quiz, and I'm glad to invite Dr. Aparna Sharma, the additional professor, Department of Obstetrics and Gynecology at AIIMS New Delhi. Dr. Latika Chawla, assistant professor, Department of Obstetrics and Gynecology at AIIMS Rishikesh. Dr. Renchen, who is the assistant professor, Department of Obs and Gynae, AIIMS New Delhi, and Dr. Jaya Chawla, associate professor, Department of Obs and Gynae, and Dr. RML Hospital. I wish all the participants a very good luck.
So, very good afternoon to all of you.
You need to shut down one system close by, please. You need to close one system close by. Thank you.
Yeah. So, a very good afternoon to all of you, and just give us 1 minute to just set the system because we will need one scorer also. Right. So, as we start with the quiz, I would like to say that preparing for this quiz has been very exciting. When we thought about the fourth topic for the workshop, we thought, okay, it has to be congenital malformation. But because we were having two panels already and we had one topic in the form of lecture, we thought maybe we can do it as a quiz. Now, when we actually started doing the quiz, then we realized that it's actually very difficult to do it as a quiz because we need to have some learning incorporated into it. So on the way, we learned a lot how to do a virtual quiz. So I have to really thank my co-quiz masters, Dr. Latika, Jaya, and Rinchin, and we have the scorekeeper, Dr. Anubhuti, today with us. The topic is congenital malformations. When we come to congenital malformations, we always find ourselves at sea. And however much we think we have the knowledge, it actually is never enough. So the questions that we need to ask ourselves when we are actually dealing with congenital malformations have to be fixed, and we really need to know that we are doing enough when we see a baby with congenital malformation. Is it compatible with life? Are there associated anomalies? Is genetic evaluation required? Is antenatal follow up required? Where and when to terminate? The mode of termination, and is postnatal evaluation required? So these are some of the questions that we need to answer. The genetics behind the structural malformations remains enigma. Mostly, even if the fetal anomaly is isolated, there are some abnormalities which are associated, and especially if there are multiple anomalies, there is increased chances of chromosomal abnormalities. So whenever we do come across fetal chromosomal malformations, we need to offer some form of testing, if possible invasive. And if it turns out to be normal, so generally it starts with a fish. If turns out to be normal, we now consider microarray. And if it is still normal, then a specialist postnatal evaluation is required. And if it is abnormal, then of course a further evaluation needs to be done. If the person declines invasive testing, NIPT does come somewhere in the picture. If it is positive, it needs to be confirmed. If it is negative, then further testing or a postnatal evaluation is required in case all prenatal evaluation is refused. Now, this is something which is a very, very gross picture. I'm sure with all the experts sitting here, and even we understand that we cannot be covering that in one slide or one frame. What we really need and what we have done since morning is a multidisciplinary approach with collaboration of our colleagues. So why the quiz on congenital malformation? It is essentially to make it interesting. The learning should be incorporated within the quiz. And I must begin by saying that it is a friendly competition. Let us not. So, yes. So let us not go very competitive on each other, and there is a spirit of participation. So how it actually has evolved is that yesterday around 5 o'clock we did the screening round. When we started, there were 9 teams from across the country. There was teams from Mamsi, Safdarjung, Apollo, Chennai. There were 3 teams, and from Kochi as well. And we did the initial screening down on the Kahoot app. There were MCQ questions, and then followed by which we selected 4 teams. And these are the final teams from Base Hospital, Mamsi. One is from the Scan Chennai, and one is from AIMS. So we have 4 participating teams. Now this, because we are doing it for the first time and this is a virtual quiz, so I would request that if there is some glitch, some technical glitch, I would request the participants and the viewers to please cooperate with us. Now there are 4 rounds, straight questions, and also that we want to make sure that the points that you are scoring is not just a fluke. We will go into the depth of the knowledge. Every straight question gets 10 marks. For every question, there is a second level question and a third level question. So if you first get the first question right, then only you will be given the second level question, which will give you 15 marks, and a third level question, which will give you 20 marks. There will be no past questions because you will obviously Google the answer in the meantime, because we cannot stop you from cheating. Now, 20 seconds for answering the straight questions, 10 seconds each for the next. You can go to the next only if you answer the first question, as I mentioned. The rapid fire round will be, there is a last round, which is the rapid fire round, for which you will have 10 marks for the correct answer and 5 marks deducted for the wrong answer. And as we all know, the quiz master's decision is a final decision. We will not have any controversies there. First thing is, I request all the participants, 4 teams, to switch on their videos. All the videos should be switched on for the 4 teams. Yes, thank you. And the quiz masters also, please, should try to switch on the video. And the audio should be switched on for the team who is actually answering. Right. So in between, once we have the condition, we will just summarize. The quiz masters will summarize that condition so that there is some amount of learning. For that is a brief learning, but there will be a learning keeping with the spirit that this was actually a teaching workshop. So keep your phone switched off on the silent mode, but please keep your videos and audios on and try not to cheat. But we have kept the time very small so that you will not be able to do that. So our scorers are ready and the timekeeper is ready, right? So we will be ringing a bell at 20 seconds. After that, if you answer, we will not be able to give you any marks. So as you can see from the picture, the first round would be about CNS. We all know who is team A, right? I would invite Dr. Jaya to conduct this first round. Dr. Jaya, are you ready?
Yes, ma'am.
Dr. Jaya?
Yes, ma'am, I'm there. I'm ready, ma'am.
Dr. Jaya, are you there?
Yes, ma'am, I'm ready.
Dr. Jaya, you need to unmute yourself.
Ma'am, I'm unmute.
Dr. Jaya?
Ma'am, I'm ready and I'm unmute.
Dr. Jaya, you need to unmute yourself.
Ma'am, she's unmute, madam. She's unmute.
I know she's muted. Doctor. I can't hear.
Can you hear me? Here?
Yes, I can hear you.
Okay, Dr. Jaya, can you please speak?
Loudly. Jaya, can you hear?
Can I go? Am I audible?
Yes, now you're audible.
Wonderful. So invite the first team on board, team A.
Okay, now I'll go on.
So the question for you is, we have a 4th gravida, para 2, living 2 lady with a background of non-consanguineous alliance. She has a prior affected child with developmental delay, hypotonia, ataxia, nystagmus, strabismus, bilateral ptosis, and rhythmic trunk protrusion. She also has an unaffected baby, and the current pregnancy up to this point has been uneventful and supervised. She presents to us as 20 weeks with an abnormality in the scan. Her prior scan, the NT&B scan, had an NT of the 50th centile. You see here images of the ultrasound, which raised the suspicion of an abnormality for which a fetal MRI was offered, the images of which are also shown to you. Take a careful look and we proceed to the questions. What is the diagnosis? Your time starts now.
It's a molar tooth sign and looks like a Joubert syndrome or Joubert syndrome related disorders, which is a part of CBT.
All right. So the next question. What is the inheritance pattern?
Inheritance pattern is autosomal recessive.
Wonderful. The next one would be, what exactly is the molar tooth sign due to?
It's basically a supra, the
several peduncles are got and
is that the cerebral peduncle you said?
No, that supra, that is no, it's a
several peduncle get aligned.
Cerebellar
peduncles get aligned.
Okay, and anything else you would like to comment upon?
And
okay. So the diagnosis was perfectly pointed as the Joubert syndrome, and you are right in saying that this is an autosomal recessive trait. The molar tooth sign is basically because of a deep interpedicular cistern, and that is caused by enlarged, thickened superior cerebellar peduncles. So we all know that Joubert syndrome is a variant of the posterior fossa malformations. It is a cerebello-oculorenal syndrome, wherein the baby presents with the picture that we presented to you, and it has a relatively favorable outcome. Team B, the question for you is?
So in this, we will give him 15 points. So team A will get 15 points. We cannot give you the third point. So good job, well done. And we will give you 15 points. So we go to the team B.
Team B, the question for you is, we have a 22-year-old primary gravida without any significant past or family history. She comes to us for a first trimester scan at 13 weeks and 5 days, and the picture of the head that we see is as shown. Take a closer look at the ventricles, the choroid plexus, and the thalami. The question for you would be, what is the diagnosis? What is the diagnosis? What is the diagnosis, team B?
Unmute yourself. Can you hear? You need to unmute. Are you unmute? Can anybody hear them?
Madam, we cannot hear them.
But I thought this. Can you hear us? But unmute yourself. Don't type.
Team B, you need to connect to your audio, please. You need to connect to your audio. Do you have a speaker, a microphone?
I think team B has typed the answer.
Okay, so what have they typed?
They typed holoprosencephaly.
Okay, so can you type the other answer?
So what is the variant with cleavage in the occipital region only? We will allow you to type in case you cannot have an audio access. 10 seconds only. What is the variant with cleavage in occipital region only?
Type it.
Please type it, madam. Please type it.
Type it in the general window. Don't privately message.
Whatever it is, just type.
Okay.
So we haven't received a chat?
No.
10 seconds over.
They have given the answer as A lobar.
Okay, so
we stop this here, ma'am, in that case.
So that is the wrong answer. So we cannot allow you to go further. So, and the third question, okay, Jaya, carry on.
That was, what is the most common aneuploidy associated with this abnormality? We won't be able to give you marks, but you can give us the answers.
And in the meantime, team B, please figure out your audio, right? Maybe you change the system and figure out your audio. So team B gets 10 marks. Okay, Jaya, take over.
Here we realize that what we see and the picture concerned was a semi-lobar form. We all know that the holoprosencephaly is the most common structural malformation of the human forebrain. And the semi-lobar variant in particular is where the basic structure of cerebral lobes is present, but it is fused. Consequently, the olfactory structures are not present, and the corpus callosum is hypoplastic or absent. It has a poor prognosis, and therefore termination is warranted. It is not compatible with life otherwise, except for the lobar variant. The associated abnormalities are very high, to the tune of 40% or so, mainly facial in nature and mainly midline in nature. Genetic evaluation is required, and a follow-up is required just to terminate the pregnancy, not to carry it forward. But prior to that, we should be offering a genetic workup of the patient. Coming to team C. Are you able to hear us, team C? Please confirm.
Ma'am.
So the question to you is, a G3A2 lady comes to us. She has missed her combined first trimester screen. She presents to us at 19 weeks and 3 days for an anomaly scan in the mid-trimester. And the picture that you see is thus. You see a picture of the ventricles, you see a picture of the posterior fossa and the spine. So what is your diagnosis?
Open neural tube defect with Arnott-Chiari malformation.
Okay. Okay. What exactly will be the recurrence risk for this lady?
In case of one previous child, that is 5% recurrence. In case of previous two same condition means 10% recurrence. In case of
we'll give that to you. We'll give that to you. The next question would be, what is a Chiari-3 malformation?
There's a herniation of the cerebellar tonsils.
Herniation of the tonsils?
Through the foramen magnum.
Yeah, that could be 2 as well. So what exactly differentiates 2 from 3? That is the question.
Actually, there is only cerebellar herniation in 3, ma'am.
No, let's go.
So the answers were, the diagnosis was a type 2 anal Chiari. The recurrence risk is between 1.5 to 3%, but 5% will give that to you. In the Chiari 3 malformation, the cerebellum herniates across the foramen magnum along with a part of the brainstem and the midbrain. And that is across the craniovertebral junction. So, ma'am, the points?
Yes,
Yeah, here. So it's
they can-
compatible with life, yes, but the 5-year mortality rate is pretty high at 35%. There is a risk of associated abnormalities, mainly genetic conditions. Therefore, a genetic evaluation is a must. A follow-up is required to look at the extent of ventriculomegaly and to offer a correction if that is they have crossed the period of termination of pregnancy, in which case a pediatric surgery evaluation would also be conducted. Where and when to terminate, it has to be standard obstetric care. However, the follow-up has to be with a multidisciplinary team consisting of neonatology, pediatric surgery, and thereafter rehabilitative people as well. Team D.
Yeah, so team C gets 15 points.
Team D, are you? Can we hear you?
Can you speak
Please
up?
confirm.
Yes, ma'am.
Yes, ma'am. You're audible,
Okay.
ma'am.
So the question to you is, a 22-year-old primary gravida with 8 months of amenorrhea, her NT-NB scan and a mid-trimester anomaly scan were fairly normal. She comes to us at around 30 weeks of pregnancy for a routine growth scan, and by biometry, the fetus is at 31 weeks. But we see this structure here in 2D that is also shown to you in the color window. So what is your diagnosis? Take a closer look at the picture.
Ma'am, this is some variceal malformation.
Could you be more specific? You're fairly correct in a sense, but
Varix malformation. I don't know. Variceal malformation. Varix vein.
So what would be the clinical presentation of the fetus here?
We cannot give marks. I think you'll have to tell.
Okay, so this was a vein of Galen aneurysm. And in case of very severe malformation, as was this one, the patient would the fetus was present as a hydropic baby. And the mechanism of cerebral injury in this case would be a vascular steel phenomena. I'm sorry, we can't give that to you.
Yeah, so thank you, Jaya, for
Thank
the
you so much,
round. And I think all of you have now got the hang of how to do this quiz, and all of you have done really well. And most of you have started scoring well. And I think we can share the scores after 2 rounds, right? So I can, to save time, I think all of you already know your scores. There's not much of confusion in the after the first round. So I would now invite Dr. Latika Chawla from AIMS Rishikesh to conduct the second round, which is and I'm sure it is quite symbolic that it is based on CBS. So Dr. Latika, please.
Thank you so much, ma'am, and a very good afternoon to all the faculty present and the participants. So cardiac defects are one of the most common fetal structural malformations, and it's actually heartbreaking to say that they are the ones that are most often missed on ultrasounds. So we'll move on to the first question, that is for team A. So a patient had missed her level 2 ultrasound as a result of the COVID. So she comes to you only at 27 weeks. Find that there is marked cardiomegaly. There is grossly enlarged with regurgitant jet arising from the annulus. You also find an ASD and reduced right ventricular outflow. So what is the diagnosis?
Epstein anomaly.
So you can see this image here from the annulus. So RAs enlarged, thick tricuspid valves, and there is a regurgitation and the jet seems to be arising from the annulus.
Tricuspid atresia.
Sorry?
Tricuspid atresia, ma'am.
It's not tricuspid atresia. So the right answer is tricuspid valve dysplasia.
Okay.
So then unfortunately we can't go on to the other questions, but just for the sake of learning, we can just share that these are usually not associated with any genetic defects.
And the cause for pulmonary atresia in tricuspid valve dysplasia is the functional, it's actually a functional cause, because most of the blood is being regurgitated back. None of his, a very little amount of it is actually going into the pulmonary artery. So it's kind of a functional pulmonary atresia.
Yeah, thank you, Latika. And I would just like to add that Dr. Abhijit, you started by saying this as an Epstein anomaly, and that is the difference, that the flow in Epstein, the annulus, here the regurgitant jet is actually from the annulus, while in Epstein the valve would have gone down, right? So that's the basic difference, and that is what we were trying to, kind of enhance. That is a difference in the ultrasonic diagnosis that we have to kind of be careful about. So, Latika.
So we move on to the next question. That is for
Just wanted to check we are audible.
Ma'am, we are audible? Yes, you are
Yes,
audible.
now brilliant. You are audible. Yes.
So the second question, there is a 28-year-old patient who's at 22 weeks period of gestation. She is referred to your clinic for a fetal echo. Why? Because she has type 1 diabetes mellitus and her HbA1c in the first trimester was 9.2. So when you did the echo, you found this is the image of the 4-chamber view, which is perfectly normal. This is the image of the 3-vessel view that you found. And this is the image of the 5-vessel view, and you put the color Doppler and you can see 2 beautiful blue vessels. So can you identify this pathology? So the 4-chamber view is normal. This is the 3-vessel.
TGA, transposition of great.
Absolutely, absolutely. Right answer. So this is TGA. So we get to go to the second question. Ma'am, may we have those slides, please? Thank you, ma'am. So what is the commonest cardiac association that these patients with fetuses with TGA have?
So,
Cardiac association.
VSD. VSD.
Fantastic. And what is the surgery to be performed for fetuses with TGA? What is the name of that procedure?
Double switch operation.
Arterial switch operation. So we'll, I think, ma'am, we can give it to them.
Yeah, it's fine.
So fantastic job done by team B. So you got all the answers correct.
So team B gets 20 points here.
So, just to summarize, this malformation, yes, it's compatible with life. There are associated abnormalities, however, they're very rare. And the ones that have been documented are associated ear abnormalities, cleft lip, cleft palate. Genetic evaluation definitely required. You need to always rule out microdeletion of 22q11. This is a duct-dependent lesion, so you need to follow up for premature closure of the ductus arteriosus. And when should you deliver and where to terminate? So delivery should be done at a tertiary care center. Like we all said, a pediatric cardiologist should be available, intensivist should be available. And cesarean should be done only for obstetric indications, and the outcome is usually favorable if they get very good immediate neonatal care. So the third question, we move on to the third question, that is for team C. So there's a second gravida, para 1 live 1. She was referred to your center at 31 weeks for a fetal echo because the radiologist suspected there is some sort of a deformity in the heart. So this is the video, what you saw in the heart. So the 4-chamber view is grossly abnormal. The apex of the heart is being formed by the right ventricle. The left ventricle is small and hypercontractile, and the 5-chamber view, you found narrow aortic root with reduced movement of the leaflets. So can you tell what the diagnosis is?
Yes, ma'am.
Sorry?
Hypoplastic.
Okay, that's the right answer. So we'll move on to the next question. So what is the commonest aneuploidy that is associated with the HLHS? Sorry?
Turner's, ma'am.
Fantastic. So next question. Ma'am, can we go to the third question?
Yes, yes.
Okay, so what is the name of the postnatal surgery protocol for HLHS?
Single ventricular repair.
No, so it's a named procedure. Can you tell the name?
3 steps actually.
Yes.
Norwood.
Okay. So right, you got the right answer there.
So team
Turner
C,
syndrome.
team C gets 20 points.
So is HL hypoplastic left heart syndrome a lethal malformation? So only 28% of all cases of HS are detected prenatally, very commonly missed. In the largest series of novel procedures, the 5-year survival is only 58%. And in one series of the survivors of the stage repair of HLHS, it was found that almost 64% had major developmental disabilities. And a detailed sonographic survey of the fetal anatomy should be performed to exclude any extracardiac malformations. And like I said, genetic evaluation needs to be done. You need to rule out the trisomies. Turner is the commonest. Along with that, T18, 13, and 21 must be ruled out. So you need to go in for an invasive testing. So when classic HS is diagnosed before 24 weeks, there is little in utero changes is likely to occur to already extremely hyperplastic left ventricle. Delivery should be at a tertiary care center with immediate availability of neonatologist, cardiologist. So we can go on to a fourth question, that is for team D.
So team C has scored 20 points. Great. So now team D.
So a patient is at 21 weeks period of gestation. She presents for a fetal echo. The radiologist has suspected a cardiac defect. So you did a 4-chamber view, which was normal. And this is what you found in a 5-chamber view. And then you moved further, the 3-vessel view is, the image is right there on the screen. So can you guess what the defect is?
It is AVSD.
No. Did they get another chance, ma'am?
No,
Can
no.
you? Okay, so this was actually tetralogy of Fallots. And you could see the overriding, the VST along with the overriding arch of aorta. So extremely sorry, you can't go on to the next 2 questions.
So can you just tell the answers?
So this is tetralogy of Fallout. And what is the most common classical form of TOF? So TOF associated with pulmonary stenosis is the one that is most common. In 80% of the newborns, TOF is associated with PS. And what is the most sensitive marker for prediction of neonatal intervention? That is direction of flow in the ductus arteriosus. So again, is this pathology compatible with life? Yes. Are there associated anomalies? Plenty of them. So right-sided aortic arch in 25%, persistent left SVC, Chart syndrome, a lot of genetic defects. So 1/3 will be associated with trisomies and another 15% associated with microdeletions. So you need a genetic evaluation, yes. Antenatal follow-up is required because you want to check the flow across the ductus arteriosus. Delivery should be at a tertiary care center. Mode of termination is like the standard care. And the unfavorable signs are when you have decelerated growth of the pulmonary artery, when there is accelerated growth of the aorta, cessation of forward flow through the pulmonary valve, and I think that if they're associated genetic or structural malformations. So thank you so much.
Yeah, so thank you, Latika, for conducting the second round so beautifully. And I think all of you are doing very well, and most of you are scored really well. So after the second round, can we have the scores, please? Can you just say the scores? Yeah, please unmute yourself.
So team A after 2 rounds is at 15 marks. Team B is 30 marks. Team C is 35 marks. And team D has still yet to open.
So, so I think team C is leading. And all of you still have one more round to go. And anyway, all of you can cover up with the rapid fire round, which has a lot of things to do. So don't feel disheartened or don't feel elated. There is still a lot more of quizzing to go. So for the third round, I would like to invite Dr. Rinchan here to conduct the third round.
Thank you, ma'am. Very good afternoon to all of you. This round is on GIT and genitourinary system. So the first question to team A is, the image provided is that of an antenatal female done in the first trimester. Okay. So the first question is, what is your diagnosis?
Omphalocele. Omphalocele.
No.
Yeah.
Okay, so
Gastritis.
okay, I cannot give you this thing because you have guessed it wrong in the first time. So the second question was on which side is the umbilical cord inserted, and the third question would be what are the common genetic defects in patient with gastroschisis. So as you would know very well that there is a difference between omphalocele and gastroschisis, that it is a smooth, it is covered by membrane, and I think you just jumped to the answer because I know that people would be knowing about it. So I think that's the thing about being very fast about answering. So unfortunately, we cannot give you the marks for this. And for the Epstein, I think we did try and give consider a second answer, but we cannot allow you a second answer here. So it is a full thickness paraumbilical defect on the right of the umbilical cord, and there is herniation and there is no covering, and it does give you a typical cauliflower appearance. So we now go on to team B.
So the second question is for team B. A 32-year-old female, second gravida, unbooked. She missed her first trimester screening and had a normal level to ultrasound. And after that, she presented at 30 weeks gestation with the following ultrasound findings. So this is the ultrasound finding of the female at 30 weeks. So the first question for you is, what is the diagnosis? Diagnosis of
Total atresia.
Yes, good. So your answer is correct. Now we move on to the second question. What is the most common neonatal mortality associated with this? What is the most common?
Pulmonary hypoplasia. Pulmonary hypoplasia.
Pulmonary hypoplasia.
I'm sorry, we cannot give you that answer. Diurnal atresia is associated with polyhydramnios, while pulmonary hypoplasia would occur in oligohydramnios. So I think you just got little confused about it. Yeah, this diurnal atresia is associated with complex congenital heart defects, which is the commonest cause of neonatal mortality in diurnal atresia. Otherwise, if it is isolated, it has got a good prognosis. The third question would have been really easy because it is associated with a genetic abnormality, which is T21. So complex congenital heart disease is the most common cause of neonatal mortality in diurnal atresia. So if isolated, it has a good prognosis. So team C.
Third question for team C. This is a case of a second gravida para1 light 0, and she has history of consanguineous marriage. She comes to you at 23 weeks, 2 days gestation with history of previous preterm IUD delivery at 26 weeks. The patient describes a vaguely deformed head in the previous fetus. Presently, she is referred to you with severe oligohydramnios on routine mid-trimester ultrasound scan. So this is the ultrasound of the kidneys, fetal kidneys. Now, first question is,
multicystic.
What? Yeah. Right? Yeah. So your answer is correct. Now we move on to the second question. What syndrome is most likely in this case? Taking her history in account.
So time is up. She has a history of a vaguely deformed head. Yes. So that comes us to the third question. Which class of disorders does this syndrome represent?
Ciliopathies.
Yeah, that's true.
Yeah.
Yes. So we'll give you 20. So which class? So this is the third part, which is the ciliopathies. So now the last question of this round is for team D.
So this is a case of a 27-year-old female. She's a primary gravida with no significant past or family history, non-consanguineous marriage, and she comes to you at 25 weeks gestation, and she has been referred with severe oligohydramnios on ultrasound. Limited fetal evaluation that was done due to oligohydramnios revealed no other abnormalities apart from the what is shown in the image provided. So the first question to you is, what is the diagnosis? Team D.
Ma'am, polycystic kidney disease.
Yes, correct. Moving on to the second question. What is the next step in evaluation to make a diagnosis of the type of polycystic kidney disease? What is the next step?
MRI. MRI and genetic testing, molecular genetic testing.
Oh, I'm sorry, your answer is incorrect.
So we cannot really give you the answer because the first step that we usually see is look at the parents' kidneys, right? So you would really want to know whether it is is autosomal dominant or autosomal recessive. So it's really simple that you do the renal ultrasound of the parents and look at the kidneys of the parents. And in this, what is the most common cause of perinatal mortality? In this, it would be pulmonary hypoplasia. So with this, we come to the end of the third round, which is the direct end of the third and the direct round of questions. So now we come to the last part of the quiz, which is so this is the differential diagnosis of the echogenic kidney, bilateral echogenic cystic kidneys. And if you have a diagnosis of bilateral echogenic cystic kidneys with oligohydramnios, you generally think of either autosomal dominant or autosomal recessive polycystic kidney disease, and you do the ultrasound of the parents. And if it is not in the parents, then most commonly it is autosomal recessive polycystic kidney disease, and then you work up accordingly. So that's a general hint that we go. Now we come to the rapid fire round. Now we actually timed ourselves and saw that the amount of time that we are taking to ask you questions is hardly 1 minute and 10 seconds. So you have actually 50 seconds to think and answer, but don't really think too much, right? If you answer correct, you will get 10 marks. If you answer wrong, you get 5 marks deducted, right? You have 8 questions maximum. The type of questions are same for all. And once you finish the 2 minutes, if you finish early and you still have 2 minutes left, we can go back. So if you don't know any answer, just say pass, right? So we can do that. So is team A ready?
Yes, ma'am.
Okay. Okay, so are the scorers ready?
Yes, ma'am.
Are the timekeepers ready?
Yes, ma'am.
Am I ready? Right. So, so first question for team A. The most important prognostic factor in the cystic adenomatide CCAM of lung is?
It is lung head ratio.
Wrong. Second gravida. The second gravida lady at 24 weeks pregnancy reports with a mid-trimester scan suggestive of facial defects, micrognathia, microstomia, cleft lip, terminal transverse defect of the upper limb. She confesses trying for abortion in the first trimester without success. Name the drug likely to be associated.
Ma'am, tablet misoprostol.
Correct. Period of gestation for feto for CDH for severe cases. What period of gestation?
28 weeks, ma'am.
Yeah?
24 to 28 weeks.
Okay. We will give you that. Most common lethal skeletal dysplasia. The thanatophoric dysplasia is most commonly inherited as?
Autosomal dominant.
Correct. On mid-sagittal plane in the first trimester, increased ratio between diencephalon diameter and Fox diameter is said to be a marker for?
Open neural tube defect, ma'am.
Wrong. Name one iatrogenic cause of micrognathia.
Valproate, sodium valproate, ingestion of sodium valproate by mother.
Uh,
Or fetal phenytoin also. I mean, hadintoin or phenytoin. You know.
So that's a drug. I would say iatrogenic. That's
Pass,
a
ma'am.
Pass.
Cardiac causes account for 50 to 60% of NIH. True, false?
True.
False. Congenital CMV is the most common cause of non-genetic sensorineural hearing loss. True or false?
False, ma'am.
False.
Okay. So how many they have got correct? So let me just set the answer. So hydrops fetalis is the most important prognostic factor in CCAM. Misoprostol, you got it right. Period of gestation, we are giving it to you. You said between 28 weeks up to, so we are giving it to you. Autosomal dominant, you got it correct. 3, and this is the marker for ACC. And iatrogenic causes actually early CVS, the procedure that you do. Cardiac causes actually account for only 20 to 40%. So that you got it false. And congenital CMV, you got it correct.
So they got 4 out of...
We got 4 out of 8 correct and 1 pass and 3 negative marking.
Right. So you got 4 correct, you passed 1, and you had 3 wrong. So we will do the calculations. So thank you. Good performance, team A. Now team B, are you ready?
Yes, ma'am.
Okay. So scorer,
Yes, ma'am.
timer. Are we ready?
Yes.
Okay. So team B, are you ready? Yes. So the management of bronchopulmonary sequestration with severe hydrothorax is. Team B, management of BPS is.
The drainage of hydrothorax, pleurocentesis.
No, BPS has something, right?
So laser ablation of the vessel,
Correct.
feeding vessels.
Yes, T3P1L1 over diabetic known case of bipolar disorders were diagnosed to have right ventricular outflow tract obstruction with defect on fetal echo at 24 weeks. Name the drug most likely to be associated.
Valproate.
Wrong. Name one indication for exit procedure.
Laryngeal atresia, congenital high airway obstruction.
Correct.
CHA1.
Okay, one indication. Osteogenesis imperfecta type 1 and 2 are inherited as
Autosomal recessive.
Incorrect.
Sorry. Yeah,
BS by BSOB measurement below the 5th centile at first trimester has been shown to anticipate the sonographic appearance of
open neural tube defect.
False. Name the most common etiology for a unilateral congenital cataract.
Rubella. Unilateral. नहीं, infection में नहीं होगा. बोल दिया अब तो.
हाँ बोल दिया. वैसे it is correct. Fetal infections account for 5 to 10% of non-immune hydrops. Anyway, you have crossed your time. So do you want to attempt this last question? True or false?
Last question not visible. True.
Okay, this is correct. So you don't have time for the last question. The risk of congenital viral syndrome is 0.5% if maternal infection occurs in the first 13 weeks. It is true. Okay, so let us see the answers. So this is laser photocoagulation. You got it correct. It is a bipolar disorder. So it was lithium. Exit procedure, you got it correct. Osteogenesis imperfecta is autosomal dominant. And that was wrong. BS by BSOB is posterior fossa. And etiology is intrauterine infection. So you named it rubella. So we are giving it. So 3 correct. And then fetal infections, you said it true. So you are 4 correct. Right? Okay. So now we go on to the next team. Team C, are you ready? Team C, are you ready?
Yes, ma'am.
Yes. So the ultrasound measurement of observed by expected LHR should be used up to 36 weeks of gestation as guided by the total trial to predict severity of pulmonary hypoplasia in isolated CDH. True or false? Till what? Okay, it is false. Unbooked primigravida delivers baby with deficient scalp at birth. She is a hypothyroid, controlled, no significant family history. Name the drug.
Pass.
Okay. BSOB of BS by BSOB of more than 95th centile between 11 to 13 has been found to predict.
Open neural.
Correct. Ellis Van Creveld syndrome is inherited as
Autosomal recessive.
correct. SFU, Society of Fetal Urology, recommends intervention at which stage of luto?
2. Stage 2.
Correct. Preauricular tags are associated with trisomy. Which?
Pass. Pass, ma'am.
Pass. NIH is due to chylothorax is associated with up to 94% survival. True or false? Time is up. Last question, want to attempt? Quick. True, false?
False.
Okay, that is incorrect. Transmission of toxo from mother to child is maximum in the first and least in the third trimester. So this is actually false because transmission is least in the first, but affection is most. So ultrasound measurements can be used up to 32 weeks and unbooked primary, the gravida. So this is methimazole, and you did not attempt this question. BSOB is open spina bifida. So this one question is correct. Ellis Van Creveld is correct. It is autosomal recessive. SFU question is correct. You said stage 2. Preauricular tags you did not attempt. NIH due to chylothorax is associated with 94. You did not attempt. And 8th question, we could not have time. Okay, so good. You did a balanced performance. Right. So now we come to the last team. Team D, can you change your fortunes here?
Thank you, ma'am.
Yes. Yes. So observed by expected LHR of less than what percent predicts poor prognosis in left-sided CDH?
1%, 25%. 25%.
Correct. A primary gravida on AED presents with few sutures, open spina bifida, cleft lip on T2 scan. Name the drug. AED is anti-epileptic drug.
Phenytoin, ma'am.
Incorrect. From mid-gestation, a BV angle of more than 45% is strongly suggestive of. BV is brainstem vermis angle.
Pass.
Campomelic dysplasia is inherited as.
Autosomal recessive.
Incorrect. Rate of survival of co-twin after RFA, radiofrequency ablation of the acardiac twin in TRAP is.
Ma'am, pass.
Okay. For chorioangiomas, the risk of NIH is 40 to 50%. True or false?
Pass. Ma'am, pass.
Okay. For confirmation of fetal CMV infection, amniocentesis should be delayed till 4 weeks from the estimated times of maternal infection till 17 weeks. True or false?
True. 6 weeks. 6.
True or false? True or false? True or false?
False. Ma'am, false.
Correct. First trimester prediction of cleft lip and palate is possible using which sign?
Ma'am, pass.
Right. Okay, this is pass. So now with that, we come to the end of this quiz. So 25% is correct. AED is valproate. BV angle is suggestive of dandy walker. Campomelic dysplasia is autosomal dominant. And this quote in survival is, this is wrongly printed. This is 80%. Anyways, you did not attempt this question to answer this incorrectly. So I think how come this is 10%? Sorry, this is 80%. For chorioangiomas, the risk of NIH is 40 to 50% is false because it depends on the size of chorioangioma. For confirmation of fetal CMV infection, the duration of from infection to testing should be 7 to 8 weeks, or at least the period of gestation should be 21 weeks for testing. And the first trimester prediction of cleft lip is possible with maxillary gap sign. So thank you, everybody. I think we had a very, you had a brainstorming session. This is the final score? Yes, please show. Yes. So again, I would like to end by saying that these are the 7 questions till the time that our scorekeeper is trying to share her screen and compile and the results which are already there. So I would like to say that we need to finally talk about these 7 questions when we talk about these antenatal malformations, and always take our geneticist colleagues, which we tried to say that when you made teams, I think all of you do have your geneticist teams along with you, and it is a multidisciplinary team management. Otherwise, management of congenital malformations is really not possible. So with that, we would like to announce the winner, and we are well in time. We finished 4 minutes early, the quiz. So Anubhuti, can you share the screen? Okay, so I will unshare. Yes. Yes. So we can see that after the first round, we had team A and C were leading. After the second round, we had team B and C, which were almost tied. And after the third round, team C was leading. And after the fourth round, which was the rapid fire, so we have the team C, which is the winner. I'm muted, sorry. So after the round 4, which was the rapid fire round, so we have the final scores here. So we have Dr. Vidya and Dr. Nivedita from Chennai. So who have won the quiz. They have the first prize, which is 75 points. And then we have Dr. Soumya and Dr. Ghazala from MAMC with 65 points, and team A, Dr. Abhijit and Aradhana from Base Hospital with 40 points, and then we have team B from AIMS. So congratulations to all of you, and I think all of them deserve a big round of applause. So I hope at least you can hear it from our side, even if not from everybody. So I'm sure all of us are clapping for you. So a very well planned effort from all of you, and we hope that you enjoyed this quiz and we were able to incorporate some learning points as well. So thank you again, and I would like to take this opportunity to thank all the faculty of the workshop for being here with us today and contributing their valuable time and knowledge to this workshop. And I thank all the participants for being here. And we hope that we did justice to your time, and we were able to contribute to the knowledge. So, ma'am, Dr. Vatsala, please some concluding remarks.
Congratulations, everyone. And I thank all the faculty who joined in for this workshop to make it a big success. And I'm proud to see many of us are students who are working as faculty in different places, or they are sort of, like Latika. Nice to see you. Jaya, Abhijit.
Pleasure, ma'am.
Good to see like our own students here. And let's hope everyone keeps this speciality in mind and understand the importance of maternal fetal medicine. And I would like to thank the AOGD team at Gangaram Hospital under the leadership of Dr. Mala Srivastava for giving us the opportunity for conducting this workshop. I thank my co-organizers, my convener, Professor Sunesh Kumar, my co-organizer, Dr. Parna Sharma, Dr. Anubhuti, Dr. Rinchen, all the faculty, all the moderators, panelists, all the people who participated in the quiz. Thank you all. And also would like to thank our sponsors and Sumit for giving us the platform. Without any glitches or hitches, we could complete the workshop. Thank you all.
Thank you so much, ma'am.
Thank you, ma'am. And in the end, I would like to once again thank my co-quiz masters for the brilliant effort. And I could not tell you that yesterday we had a brilliant experience with the Kahoot app and conducting the virtual quiz. And it was a new experience for all of us. And I'm sure this virtual platform is teaching new things to all of us. So thank you, Latika, Jaya, and Rinchen, for this new knowledge that we have gained by conducting the virtual quiz online. And I would like to thank my co-conveners also, Anubhuti and Rinchen, for all the effort, and Sumit for the excellent coordination from the very beginning. So thank you once again, all the faculty and the delegates and the coordinators and the co-conveners. Thank you so much.
We will take this opportunity of saying a big thank you to you, ma'am.
Everybody can have lunch. We really wish we could have it together, but hope to see you sometime soon.
Great. Thank you so much, ma'am. Thank you for the opportunity.
Ma'am, for letting us stay connected. Thank you so much, ma'am, for the opportunity.
Dear doctor, pregnancy is a beautiful journey in a woman's life. A journey where she needs care and your expert advice. As her body goes through a 9-month-long transformation, she requires extensive nutrition. Nutrition that nurtures her growing baby and helps her navigate through some unpleasant experiences of pregnancy. Introducing Trimacare, 9 months of extraordinary care for an extraordinary role. A prenatal pill designed to fulfill complete nutritional needs of Indian pregnant mothers. Trimacare 1, 2 and 3 are specially designed for each trimester of pregnancy and the growing needs of mother and child at each stage. Trimacare is formulated by experts following the ICMR guidelines. It's made with iron, folate, calcium, vitamin D, omega, and more than 25 nutrients essential for a healthy pregnancy. Trimacare adheres to multi-micronutrient supplementation known to reduce risks of low birth weight, preterm births, and babies born small for gestational age, and also helps in fetal neurodevelopment. With the right ingredients, Trimacare helps reduce commonly experienced symptoms in pregnancy like nausea, vomiting, morning sickness, constipation, UTI, leg cramps, and hypertension. Trimacare is free from allergens, is non-GMO, has higher absorption value, is gentle on the stomach, is 100% vegetarian, and is made with premium ingredients. Dear doctor, now no more trouble of prescribing multiple pills to your pregnant patients. Choose trimester-wise care. Choose the right nutrition for Indian pregnant mothers. Choose Trimacare.
Thank you, ma'am.
Thank you.